a meeting. So this is a post meeting of the tetralogy of Fallot from a sick kids meeting that was yesterday and the day before yesterday. And now we are having a practical hands-on online course with tips and tricks about tetralogy of Fallot. It's very interesting using 3D print models. It's very nice. Sasha is one of the proctors, and I'm sure it was a very good opportunity for surgeons to learn something different about tetralogy of Fallot. And please join us on Monday with Dr. Normal Silverman imaging series. He correlates morphology and echo imaging on his series. Is very nice. And he's going to have 2 sessions about functionally single ventricle. The first one is this Monday. Please join us. And in the end of the month, we are going to have our fetal series. This is going to be a lot of topics from our colleagues from Italy. It's going to be nice. And next Friday, I forgot to place the flyer, but next Friday we have Dr. Bob Anderson talking about isomerism. He made the first session yesterday, and next Friday he's going to have the second part about anatomy and morphology of isomerism. I'm sure this is going to be nice. And now with you, Gil Wernovsky. Thank you, guys.
Good morning, good afternoon, good evening. I am really just sort of blown away by the response that I have had from the fellow panelists in this session, who on very short notice agreed to put together a short sort of high-level presentation to sort of put on the map where we are now with the treatment and outcomes of hypoplastic left heart syndrome. This is an area of active work and research from everyone on this screen. And I think you'll be learning from some of the world's experts. There are so many webinars now. I think it's fantastic. This is one of the unexpected positives from the pandemic. For those of you new to the Congenital Heart Academy, we've put on nearly 100 webinars now since lockdown at the beginning of March 2020. Grace, I think we have, what, 25,000 unique visitors and 170,000 YouTube views at this point. Is that pretty close? Yeah, and from all countries but 5. I have to look and see what the 5 countries are and see if we can.
We need to talk to them for sure.
No, we have some work. We still have some work to do. So this is going to be informal. I know we get a lot of PowerPoint presentations that come on, and you get 20 minutes of this and 20 minutes of that. And very, very important. I know you have 2 options on your Zoom controls. One is a chat box, and it's great to hear from people that are logging in from all over the world. Specifically, though, if you have questions for any of the people on the panel, even if they're not speaking at the time, you can put that in the Q&A box. So we strongly, strongly encourage your questions go in the Q&A box, not the chat box. Let me see. I want to look at my agenda here and be sure that I have them. Okay, I'm going to show a quick video, assuming that I can get my my screen going here. Give me just a second. Let me know if there's any problem with that, Grace, please. Do you see that?
Yes, all good, and the sound is good.
Yes, there was something wrong because they could hear this strong noise coming from my chest. I remember the day of the operation in the operating room, and I looked up and it was all these men looking down. There was students, and I remember the nurses and the anesthesiologist. And then the next thing you know, when I woke up, I was in a crib. And I said, Dr. Belloc, I stand in awe and admiration of your surgical skill. But the very great day will come when you build me a ductus for a cyanotic child, and not when you close the ductus for a child who had a little too much blood going to the lung. He gave a sigh. He really thought he'd done it. And he said to me, when that day comes, this will seem like child's play.
In 1955, this 7-year-old girl was carried into the heart hospital by her parents for intracardiac correction of the tetralogy of Fallot defects.
And the revelation that open heart surgery could be carried out with a few lengths of plastic tubing, some clamps, and some oxygen had a explosive effect on the growth of open heart surgery worldwide.
Prior to the development of this technique by Dr. Ashkin and his associate, Dr. William Miller,
No mask.
dangerous heart surgery was the only course available for the 3,000 to 4,000 babies born each year in the U.S. with this defect.
Now that's the balloon being inflated in the left auricle. Now that's maximum inflation, and I'm going to pull it back into the right auricle now. You see that we're the world's fastest operation.
Megan Adams Roswick was born with half a heart. Without medical intervention, the condition is 100% fatal.
Also ahead, a baby born with half a heart faces a 100% chance of death.
Given no chance to live, but here is a phenomenal story.
Is a matter of life or death for some. At least it was for Megan Roswick.
He said that this is the single worst defect that a child can be born with.
If you imagine that this truly is just abnormal plumbing, then we've got a structural problem, and structural problems lend themselves to structural solutions, reorganizing the plumber. So the people that reorganize structure generally are surgeons.
And then, of course, Bill did fantastic stuff. It was tough because he did not have that enthusiastic following by the cardiologists, to put it mildly, for that thing about the hypoplasty. And it was tough, and he fought it through. And he had different, there were different approaches. Initially, that didn't work out and so on, but finally he succeeded.
Good evening, everyone. A 14-day-old baby girl is fighting for her life tonight after receiving the heart of an infant baboon. It has never been done before, not successfully, and not on a patient so small.
Doctors praised the so far successful transplanting of a baboon heart into the body of a baby girl who was certain to die.
My options that were given to me were, you can leave her here and let her die. You can take her to Barstow Hospital and let her die. Or you can take her home and let her die.
I became deeply impressed with the fact that we've seen a number of babies with incurable heart disease, incorrectable heart disease, babies at whom you could only experiment surgically with. And it impressed me that what those babies needed really was heart replacement.
I think Baby Faye's legacy has to do with the hundreds of babies that are now alive who would not be on our planet without her experience.
I must say, every time I watch that, I'm in awe. I do want to dedicate this entire session to three pioneers in particular who we've lost in the last couple of years, which is, of course, Dr. Norwood, Dr. Bailey, and Dr. Castaneda. We would not be sitting here if it wasn't for the work that they have done. I remember as I think I was a second-year pediatric resident when the Baby Faye story broke, that a baboon heart transplant had been done. And that was part of what cemented me to go into pediatric cardiology. And I've had really the great fortune of watching the care and outcomes for children with hypoplastic left heart syndrome evolve over the last 35 years. And the reason that the panel was picked today is they have been doing the pioneering work in figuring out A, how the kids are doing, and B, what can we do differently to make it better in the future? And that should always be our goal. So with no ado, with no holding back at this point, Mark, I've been practicing this, but I don't know if I'm going to be able to do it. Mark is joining us from Leuven in Belgium. He said before we started that we can pronounce his name any way we want. It will always be wrong. But we're going to start with Mark Velig, who I think understands this physiology better than just about anybody. I've learned so much from you, Mark. Thanks for joining us.
Okay, thanks, Gil. So I was asked to say a few things about fundamental elements in the Fontan circulation and whether they could be flawed anyway. I have no disclosures concerning this presentation. Now, when I started being trained in pediatric cardiology, and when I first saw Fontan operations, what were the fundamentals then? Well, I was taught that a Fontan operation was a very complex cardiac surgery that needed to be done by the best cardiac surgeons. It was a surgery typically for complex congenital heart disease, requested by pediatric cardiologists and performed by pediatric cardiology surgeons. Very early on, we already saw that there were major problems, and it looked like the ventricle had some problems with coping with the afterload. We saw a lot of congestion, low output, and the cardiologist was confronted with a big, dilated, and dysfunctional ventricle. So that immediately led us to the concept that there was a severe degree of heart failure. And when you say that word, all cardiologists will go to heart failure strategies. And as you all know, I mean, it will involve dealing with contractility, heart rate, afterload, and preload. And as you know, we are all trained as cardiologists in this formula, where cardiac output is related to the volume you get, the contractility, heart rate. And we were specializing then in treating the failure and improve that circuit at any possible level. Now, although all this sounds very good and very what we're used to, it ended up with a lot of frustration. By the way, if we had to learn the hard way that, for instance, if you improve contractility where we would expect things to improve, nothing happened. If you fiddle around with heart rate, you increase or decrease a little bit the heart rate, it doesn't do anything to the output. If you lower the afterload, nothing happens. And preload, I'll come back to that a few times. We're dreaming about increasing the preload to the ventricle, but that's where the big problem is. And also this formula, we learned, so as I already said, if you increase the heart rate, well, these factors will go down so that cardiac output doesn't do a thing. And treating failure at any possible level, I think most of us have dealt with improving minor things, for instance, a mild coarctation or something that may have given a very nice angiographic result, but didn't end up in a significant improvement of the circulation. And so what we have learned the hard way is that we have to be much more careful about some very basic fundamentals of what is exactly the primary insult we are doing to our patient, what are primary and secondary changes, what are independent variables, what is a bottleneck and how should you deal with it, what is the definition and the implications of a critical bottleneck, what is the diastolic function, or how should we define it, and what should we do with negative studies. Now, before going on, I think most of you will be acquainted with this kind of graph reflecting a Fontan circuit. So where the pulmonary vasculature over here is put between the systemic vasculature and the left atrium. Now, the big question that we should ask first is, this pulmonary vasculature, is it now put downstream of the ventricle, or is it being put upstream of the ventricle? And you're going to say, what a silly question. Does it have any implications? Well, it determines enormously the way we are thinking about a Fontan circulation. For instance, if we say that it is downstream of the ventricle, then you could postulate that somewhere the overall resistance might be increased. And there were many people would use the electrical model, by the way, which I think is wrong. But you could postulate that the ventricle could easily then push the blood through the whole system. And thereby you keep a very central role for the ventricle. You expect that ventricle to fill the venous pool. And you would expect that after Fontan, because you increase the resistance, that aortic pressure would be higher, systemic vascular resistance higher. That explains the hypertrophy. The cardiac output would be lower because there is more afterload, and you would expect an effect of vasodilators. Now, attentive people that were listening to me will have said, well, I've been saying here quite a few things that doesn't match up. That's not what we see in a Fontan circuit. So it would be worthwhile to see if we could look at the Fontan circuit the other way. Maybe that the pulmonary vasculature is put upstream of the ventricle. And that automatically would explain the upstream congestion that we see in the systemic veins and the downstream low flow that we see throughout the whole system. And if you consider this, then automatically you expect aortic pressure to be lower than normal, cardiac output to be decreased, systemic vascular resistance to be increased because your output is low, and you would expect no effect of vasodilators. That is something we see much more often in our patients. And indeed, we can go on with this discussion for quite a while, but I think it is a much better way to look at the Fontan circuit as being a dam being put upstream of the ventricle. And so if you have your dam over here, automatically here you see the systemic venous congestion and the decreased low flow that is already low by the time it gets to the ventricle. We all have seen excessive damming, where we have excessive low output, excessive congestion with all the features we don't like, and residual cyanosis. Now, a few basic questions, very fundamental questions. Can the surgeon make a Fontan circuit without touching the ventricle? Well, I think every surgeon nowadays can confirm that he can create a Fontan circuit without even touching the ventricle. And that is in our mind a little bit because they're just next to each other, but this is vascular surgery. You don't need to touch the ventricle. But this answer has major implications for a Fontan circuit. It means that as the surgeon did not touch the ventricle, everything we see at ventricular level will be a secondary phenomenon due to the new boundary conditions. And then this is a general rule throughout the universe. If you alter secondary phenomena, you're rather unlikely to alter or to improve the primary insult. Now, there is a few exceptions. So the primary insult is actually the extracardiac surgery, the vascular surgery, nowadays, caval veins to the pulmonary arteries, with everything at ventricular level being secondary. 5 exceptions. Which are the 5? Sometimes the surgeon can do a short arrest, for instance, do a septectomy, but that is very unusual at the time of a Fontan. Cardioplegia, if he has to do things like this, or a ventriculotomy. But again, all these 3 things are extremely exceptional to be done at the time of the Fontan. In the 80s, we went from highly shunted patients to a full Fontan. And in those days, it was possible that you could unload the ventricle to such an extent that it was operating close to its closing volume. Next slide will deal with that. And then the 5th, but this is nowadays exceptional. And the 5th thing is something we impose on all our patients. The Fontan state itself will lead to a decreased compliance of the ventricle. We can discuss how this happens, but this would be a talk almost by itself. First, a few words on the closing volume. This graph over here that reflects the relationship between stroke volume and end diastolic volume does not go through 0. So it means that there needs to be a minimum preload for the ventricle to contract. Now, that used to be a problem in the 80s. Now that we go no more from a double shunt to a Fontan, but first from a shunt to Glen and from the Glen to the Fontan, this very, very rarely will happen. But what will happen in nearly all our patients is the diastolic features. We see with time that the filling pressures, the stiffness of the ventricle will increase. And indeed, as time goes on, what are the changes that we see? Well, the primary changes with time will be that the pulmonary vascular resistance will go up a little bit, and the end diastolic pressure will go up even more, resulting in these changes of the graph with an increased central venous pressure, an output that is decreasing. Ejection fraction obviously will have to go down. The lesser the preload, the lesser your ejection fraction, and systemic vascular resistance has to go up in order to maintain your blood pressure. These are the secondary changes. These are the primary changes, extremely important when we will be talking about how to manage the problems. But then again, some very, very fundamental hydrodynamic issues. And as I said, as cardiologists, we are more or less would-be hydrodynamic engineers. And in engineering, this is very, very basic. Every engineer will confirm this. If you have a flow over here and you impose a resistance, how can you deal with the effects of that new resistance? Well, you can push harder, you can deal with the resistance over here, or you can pull down below. And if you then ask what is the easiest or the efficient, well, dealing with the obstruction over here will be the most efficient, but pushing harder upstream will be the easiest, and pulling more downstream will usually be the least effective. And then another major issue, very, very fundamental issue, is how should you deal with multiple bottlenecks? Here you have multiple bottlenecks, and with a blinking of an eye, everybody will have seen where is a critical bottleneck. In other words, dealing with an obstruction over here will not influence the overall flow throughout the whole system. In a system like this in series, there is always only one critical bottleneck, and it's the only one, the only thing to work for. All the other bottlenecks, to be honest, are irrelevant. If you change something over here, nothing will change in the overall system. And that leads us to the big question. Now in our Fontan circuit, where is the critical bottleneck now? Now, one easy way to determine where the critical bottleneck is, if you do a maneuver like a bypass, which will resolve or neutralize the effects of your action, that's where the critical bottleneck will be. And the fenestration is a very, very nice example of this item. If you make a connection from here till there, you will decrease the congestion over here and you will increase the flow over there. So by this fenestration, therefore, proves that the critical bottleneck now in the Fontan circuit is over here. And it consists of the Fontan connection itself, the big arteries, the pulmonary vascular resistance, the pulmonary veins, and then the flow through it will be determined by the push over here and the pull from the ventricle. Again, another fundamental concept is, what is a pressure pump and a suction pump? Very fundamental. Now, ask any engineer or ask any fireman, they will tell you exactly what the difference is. The pressure pump is something like this. We are used to as a cardiologist as well. That's what the fireman will use to put out a fire. However, if they run out of water and they have to get it from a lake or a pool or whatever, they will use a suction pump. And sometimes you have a pump that can do both. You have a pressure suction pump. Now, if you know the graphs of the ventricular pressure, that's this. And so what we love to call a pressure suction pump, actually, if you tell that to an engineer, he will start smiling at you because he has a completely other idea of what a pressure suction pump is. By the way, if our ventricle would be like this with real suction, there would be no Fontan problem at all. You would suck the blood through the lungs. Now, some formulas, because we are engineers. What are the determinants of the flow? Well, and this is a model of cardiologists typically for congestive heart failure. Now, typically over there, the left ventricular preload will be unlimited. That's almost the definition of congestive heart failure. Heart rate is being determined by all these factors. And over here, I should put the left ventricular afterload. Within limits, it will work with the contractility. We all know this formula, but the independent variables in a typical heart, like in congestive heart failure, you have preload, heart rate, and diastolic volume and contractility, leading to this formula that we all know oh so good. That is standard classical cardiology. Now, does it still stand true? Are these fundamental principles, can you extrapolate them to a Fontan circuit? Well, a lot of variables will shift from primary to secondary. For instance, the preload in a ventricle, now in a Fontan ventricle, is limited. That's almost the definition of a Fontan circuit. The preload is limited. The heart rate still has all these variables, but the Bainbridge reflex, in other words, the venous return, will not be able to influence it as much as possible. The afterload itself, well, there will be less volume against similar or lower pressure. In other words, you can say that the afterload will be decreased. And actually, the only independent variable that is still existing is the preload. And what we have to say is that the preload, the cardiac output actually will now equal the ventricular preload, what is allowed to go through the lungs. And obviously, this formula still stands over here, but it is now full of secondary variables. The real primary variables are over here. The flow throughout the whole system will be determined by central venous pressure, the suction, and the resistance throughout the whole system. And in time, indeed, what do we see? PVR will go up, the filling pressure will go up, also central venous pressure. This will result in this with net result decrease in cardiac output. And it are exactly these two features, the decrease in output and the increase in central venous pressure, that will make our patient worse in time. Now, this formula immediately also suggests that if you want to study the effect of a drug or a maneuver, you have to measure at least these 4 variables. If you don't measure these 4 variables, you will be looking at the shadow of the action. And obviously, that's never good. Another thing that you can draw from this formula is if you make the study, if you don't change, if you make a drug, if you study a drug and you don't change any of these variables, nothing will happen in the Fontan circuit. Indeed, the independent variables are now this, and as you see, nowhere you will see here ejection fraction, systemic vascular resistance, or heart rate in this formula. It's only when these become so bad and they will alter one of these, usually it will be the filling pressure, that the output in the whole system will change. But as themselves, as long as they don't change this, nothing will happen. So how do we get more flow through the bottleneck? As I said, the basic rule, either you push harder, you deal with the bottleneck, or you pull harder. Pushing harder is what the patient does. The only way the patient has to get more flow through his Fontan circuit is with his muscles. As he starts using especially his legs, he will get more blood through it. We also can do that, for instance, with an RVAD or with transplant if necessary. The bottleneck itself is dealing with the resistance. So you can deal with all those factors over here, the vasodilators, but we know that the effect usually of all these will be limited. And as I said before, pulling at the end of the bottleneck is usually the hardest to do, the least efficient. We are dreaming of lusitropic drugs, but to be honest, we don't have any. And why does the ventricle become stiffer? Well, we can discuss about it, but it's almost a talk by itself. Stretching the deprived ventricle is not easy at all. If you then predict what the therapy will be, well, more suction at the end of the circuit is, I probably should have said 0% efficacy. We don't have any ways at this moment. Working, for instance, with the pulmonary vasodilators, multiple studies have shown that in individual patients, the most they have ever seen is 10% increase in output. Usually for the whole group, it's much less than that. Getting a muscle pump, the patient will be able to increase his output. That is the most efficient, or put a pump by ourselves. So last slide. What can we say about the fundamentals? That were the fundamentals we started off with, but what are the real basic fundamentals? As I said, it is non-cardiac surgery. We don't touch the heart. To do the essence of Fontan is non-cardiac. The heart is big, overgrown, and dysfunctional, but predominantly because of the secondary phenomena. There is a big difference between systemic vascular resistance and afterload, and many people sometimes mix that together. I think I made the point that heart failure is a very bad word when we speak in a Fontan circuit. What we all can agree on is a circulation failure, And because there is a new critical bottleneck, I mean, you have to concentrate on how to get the flow through that bottleneck. That's either the connection itself, pulmonary vascular resistance, or, and here the ventricle comes back into the system, how much suction you have at the end of the circuit. This formula still describes the circuit, but if you want to alter the circuit, I mean, if you don't alter any of these variables, you will see no change whatsoever. And what we have learned also is not that you should treat failure, but avoid it, and not at any possible level, but the most efficient will be to work within the critical bottleneck. Otherwise, you will be doing things that are of no value. So to answer your question, Gil, are the fundamental elements fundamentally flawed? Of course not, but you have to go for the real fundamentals with respect for primary changes, independent variables, the critical bottleneck. That are the real fundamentals in every hydrodynamic circuit. I thank you for your attention.
Gil, you're muted.
You're muted, Gil.
I was saying all these great things about Mark. I'm sorry, Mark. You put decades of work and days worth of research into a wonderful 15-minute presentation. We run tight in these, but I'm going to ask you one question, take moderator's privilege, and that is, what are your thoughts on an RV to PA conduit SANO and hypoplastic left heart syndrome when at least 3 times you've said don't touch the ventricle?
The point I wanted to make is that the essence of a Fontan circuit and the problems we see, we also see them if you don't touch the ventricle, yeah? And so we should not blame the ventricle for all the bad things we see afterwards, because you also will see them without even touching the ventricle. Obviously, a SANO may enhance the problems. It will not decrease them, but there, in my own experience, the SANO has some advantages and disadvantages. The advantage is that the initial surgery in some teams will be easier in the intensive care. Yes, you will have some ventricular damage, but don't blame all the late bad things of the Fontan circuit to that scar of the SANO. I think there are major other things. And so I'm a very, very strong believer. If I see a failing hypoplast, usually when I look at the pulmonary vasculature and the growth of the pulmonary vasculature, I have enough explanations why the circuit fails. And the ventricle very frequently will be the innocent bystander. It will be rarely the primary cause of the late failure, but it is the easiest thing for us to measure. We will see a bad ventricle and we say the circuit is failing because of the ventricle. I think the reality is a little bit more nuanced. If you have a very bad pulmonary vasculature before the ventricle, you have a big dam over there. I mean, whatever ventricle you put behind a very restricted dam, the ventricle has nothing to do and will do almost nothing.
Thanks, Mark. I again want to remind my colleagues and friends to take a look in the Q&A box. People, please put your questions in there. Anyone feel free to answer that. Grace, is it okay if I introduce the next speaker? He's a dear friend, and I will hold off on a lot of the stuff that goes back into this. Jeff and I have known each other for a few decades now. We are really privileged to be the co-hosts of the 8th World Congress of Pediatric Cardiology and Cardiac Surgery, which will be here in Washington, D.C. In August, the end of August in 2023. Jeff is going to tell us a little bit about that, and then he's going to move forward from there to talk about how we're measuring outcomes for children and young adults with hypoplastic left heart syndrome. We've set up this panel today to work sort of in 2 parts. Mark spoke at the beginning about what we've learned about the physiology and where the critical issues are. I'll be speaking at the end to be as controversial as possible. My colleagues from Washington and other locations will know that that I like to poke the bear, so to speak, as much as possible. And in between all of that, we're going to share data and thoughts from a variety of experts around the world. So Jeff, why don't you take it away from here?
You bet. First of all, can you guys see my slides okay?
Looks great.
Awesome. So first of all, thank you, Gil, for letting me be a part of this webinar. I've been tremendously impressed with all of the accomplishments of Congenital Heart Academy since we were hit by COVID. And it's really transformed the way pediatric and congenital cardiac care can educate all members of the healthcare team. I've had the honor of sitting and listening to several of these webinars and participating in a few, and it's just wonderful. So thank you for all that you've done. My task here is to give a brief update on the World Congress, which is kind of a project that Gil and I have been collaborating on for over a decade now, and then to talk a little bit about the role of databases in measuring outcomes and measuring improvement for patients with functionally univentricular hearts, and specifically patients with hypoplastic left heart syndrome. So let's talk first a little bit about World Congress. I think, as this slide shows, the plans were to hold the World Congress in Washington, D.C. This coming September. We had everything all put together, and we had a faculty of 1,000 people. We had hotel rooms booked for 5,000 people in Washington, D.C. for an entire week. And then it just didn't come together because of COVID. And when that happened, we had to kind of regroup and come up with new plans. And right now, we have a new meeting scheduled for 2023. We've got 15 hotels booked. We've got a faculty of 1,000. We're going to have a global and advocacy village. We've got professional conference organizers that are helping us plan this wonderful meeting. We have a CME application that's been submitted to Hopkins. We have continuing education for the nurses. We have a $6 million budget, and the meeting is really well underway for 2023. We have 66 institutional partners that are listed on this slide. These are all organizations that have helped put together the meeting, sponsor the meeting, fund the meeting, and will be present on the faculty, and many with special breakouts and symposium. In addition to that, we have 51 societal partners. These 51 societal partners represent the full spectrum of pediatric and congenital cardiac care, surgery, cardiology, anesthesia, critical care, nursing, perfusion, parent advocacy groups. Of these 51 societal partners, 19 have previously canceled their meetings in order to have a meeting with the World Congress instead of having a simultaneous meeting that year. And even more importantly, 12 societies are embedding their meeting within the World Congress. This includes the Cardiac Neurodevelopmental Outcomes Collaborative, Pediatric Cardiac Intensive Care Society, World Society for Pediatric and Congenital Heart Surgery. And the partnership we have with all of these organizations, as well as the Congenital Heart Academy, is a partnership that's valued tremendously by World Society, by World Congress. This slide is a slide that shows the members of our organization committee and how our committee is put together and the structure of our committee. We've got a lot of people that are working quite closely together. And with this committee, we've put together an outstanding program for 2023. On our website, the details of our 2023 program are all listed, and we encourage everybody to visit our website, plan to join us in Washington, D.C. in 2023. We've got all the I's dotted, all the T's crossed, and we're planning an absolutely outstanding program that's going to combine face-to-face learning with webinars and webinar learning. The best part about it, to be quite honest, is it's going to give us a chance to all be together. By then, COVID hopefully will be all over, and it'll be nice to all be in the same room. Gil, I'd like to give you the chance to say a little bit too, since you know, this is obviously your baby and you've been working on this for years.
I really don't have very much to add, Jeff. The website that's up there now, of course, is the old one. It's wcpccs2023.org. It's at this point a placeholder for the most part, but leave your email address and you will get updates as we move forward.
Yeah, it's going to be very exciting, and we're looking forward to having everybody join us. And I think that with that, probably what I should do is transition to the real assignment that I have today, which is to talk a little bit about databases and registries. So I'm going to put this slideshow up here like this. And what Gil really asked me to talk about today is how do we use data and how do we use databases to learn about a disease, in this case, hypoplastic left heart syndrome, and get better at what we do and make lives better for our patients and their families. No disclosures. The first part of my talk, and this is going to be a pretty rapid talk of under 5 minutes that hits the highlights of data analysis and databases. The first step to analyzing any disease, including hypoplastic left heart syndrome, within a database or registry is using a common terminology or nomenclature to describe that disease. And at ipccc.net is a nomenclature system that's now used in really all multi-institutional databases and registries for pediatric and congenital cardiac care, and is going to be incorporated into ICD-11. For the purposes of this talk, I just wanted to highlight 2 definitions that we use in our databases to be on the same pages. Maybe. So all of this information that we're going to talk about is published in this article that's published in Cardiology in the Young that talks about the nomenclature for pediatric and congenital cardiac care and ICD-11 specifically, as well as the International Pediatric and Congenital Cardiac Code. Like I said, there's 2 definitions.
Jeff, it's Gil. I want to interrupt you, and I just want to let all of the participants know that a lot of our slides today are going to go by a little too quick to write down all of these references. If you'd like to go back to them, they'll all be on our YouTube channel. So for all of the speakers, any one of your references, everybody can look at them later in our recorded session. Sorry to interrupt, Jeff. I just want to
absolutely. And beyond that, if anybody wants a copy of my slides, if they send me an email, I'll just send a copy of the slide deck directly. So this is the definition we use for hypoplastic left heart syndrome in our multi-institutional registries. It's important to understand all of the components because this is how we use data to improve quality and outcomes. So a spectrum of congenital cardiovascular malformations with normally lined great arteries without a common atrioventricular junction, characterized by underdevelopment of the left heart, significant hypoplasia of the left ventricle, including atresia, stenosis, or hypoplasia of the aortic valve or mitral valve, or both valves, and hypoplasia of the ascending aorta and aortic arch. There's many related malformations to hypoplastic left heart syndrome, but this is the precise definition used in our databases for hypoplastic left heart syndrome. Many of the related malformations that may undergo a Norwood operation that are not hypoplastic left heart syndrome are other forms of functionally univentricular heart, such as double inlet left ventricle with transposed great arteries or tricuspid atresia with transposed great arteries. And those form under this heading of functionally univentricular heart, which is a spectrum of congenital cardiac malformations in which the ventricular mass may not readily lend itself to partitioning that commits one ventricular pump to the systemic circulation and another to the pulmonary circulation. So this is what we call a functionally univentricular heart in our databases, a term that is synonymous in many centers with single ventricle. Now with that, I just want to talk a little bit about databases, and this is going to be a rapid run through multiple databases. I'm going to spend about 3 to 4 minutes at most talking about the different databases that investigate outcomes of patients with hypoplastic left heart syndrome. And there's a whole pile of these: the Society of Thoracic Surgeons Congenital Heart database, the European Congenital Heart Surgeons Association database, World Database, UNOS, Pediatric Heart Network, PC4 and NPC-QIC, which we'll hear about later, and a variety of other global registries. Specifically, one that I think is very helpful for this topic is the Australian and New Zealand Fontan registry. The STS database represents the overwhelming majority of heart centers in the United States. So there's 125 hospitals that perform heart surgery in the United States. Almost all of them submit data to the STS database by now, as shown by this slide that shows the growth of the STS database. That allows us to analyze in a 4-year analytic window 160,000 operations done on children in the United States. And the whole database now has actually over 500,000 operations. Our partner database in Europe represents 403 centers with 194 centers in 52 countries actively submitting data. I wanted to just show a few key facts from these databases that sets the stage for why we think about hypoplastic left heart syndrome the way that we do. We use a precise definition of operative mortality in these databases, which is a child that dies after heart surgery, either before going home or within 30 days. And these definitions are important when we start looking at outcomes in databases. Interestingly, if we look at how many Norwood operations are done in the United States, in a 4-year window, we have 2,700, or about 650 to 700 Norwood operations are done a year. And the aggregate mortality is about 15%, using that previously described definition of operative mortality. Now remember this number, 650 to 700 Norwood operations are done every year. The reality is that substantially more babies are born every year with hypoplastic left heart syndrome than donor hearts are available. And this is why transplantation alone cannot be used to solve this problem. And here's an interesting set of numbers from UNOS. In 2014 to 2020, in UNOS, this is the number of infant heart transplants done every year. 120, 127, 130, somewhere between 120 and 130 infants get heart transplants every year. Meanwhile, 650 to 700 neonates undergo the Norwood operation every year. And this is just data from the United States, but I think it shows why transplantation alone certainly is not ever going to be a solution in the current era. Now, the next thing I want to do is just fly through a series of articles that have been published from a variety of different databases to show the type of knowledge that can be learned from databases about hypoplastic left heart syndrome. The SVR trial that randomized infants to 2 different types of Norwood operations is a great example of a multi-institutional registry. As everybody is aware, this trial randomized infants, neonates, to 2 different types of the Norwood operation with a Sano shunt or with a BT shunt, and survival was compared between those 2 shunts as shown on this graph. What's really more important than even the analysis of survival from this New England Journal article is the multiple dozens of articles that have come from this database looking at all aspects of patients with hypoplastic left heart syndrome. For example, there was a paper that looked at this is a paper by Rick Oye that looked at the comparison of different shunt types for single ventricle procedures. That was in the New England Journal. And this is the New England Journal paper that we just talked about that concluded that transplantation-free survival at 12 months is better with the right ventricle to pulmonary conduit than with the modified Blay-Lactausic shunt. After 12 months, though, the survival difference really disappeared and the survival was similar between the 2 groups. Like I said, this is the finding of the article in the New England Journal, but let's look at all the other research that was done from this same cohort of patients. So we can see here an article where we looked at variation in perioperative care across centers for infants undergoing the Norwood operation. Then we were able to look at developmental outcomes in children with hypoplastic left heart syndrome. Then we were able to develop predictive models for neurodevelopmental outcome. This is some work that was done by Bill Maley and colleagues with the same data set. Then after that, we were able to look at a study that looked at transplantation-free survival at 3 years. Then the same cohort looked at factors associated with neurodevelopmental outcomes later in childhood. Then transplantation-free survival at 6 years, led by Jane Newberger. And this is the graph from the transplantation-free survival at 6 years, which shows that although the RV to PA conduit's a little bit higher, actually the p-value is 0.08, so it's no longer statistically significant. Now, we talked before that we did research with this cohort looking at variation in outcomes after the Norwood operation. Then we were able to look at variation in outcomes after the Glenn operation, after stage 2. This is great work done by Aaron Eckhauser. And then after that, we were able to look at variation in outcomes after the Fontan operation. These analyses looking at variation in patterns of practice and outcomes are very important because they allow us to see what is being done differently at centers so that we can learn from one another and find ways to do better. So this rapid fly through all the different work that's done by the SVR trial is one example of work that can be done by a database. I have a couple of other things I'd like to show. This is the latest study from the Society of Thoracic Surgeons database that looks at evolving surgical burden after Fontan failure and looks at the entire STS cohort of Fontan patients, including those with hypoplastic left heart syndrome. And then, as I said before, the Australia-New Zealand Fontan registry has also some very valuable information about patients with hypoplastic left heart syndrome and includes a fair amount of data that comes from parents and families as well, which I think is a unique advantage of this data set. So what I've tried to do in the 5 minutes that I've been given to talk about this topic is show how there's a whole pile of databases that look at patients with hypoplastic left heart syndrome, and the amount of information that can be gathered from these databases is massive. I really tried to use this information to show that these existing databases and registries that exist worldwide allow us to look at what we're doing and find ways to do it better. And there's lots of registries. They're all complementary, and a lot of research is now being done to find ways for these databases and registries to talk to each other. And I think my last slide just says that data is power. The data in these databases is very powerful, and it allows us to learn multiple lessons, as shown by that rapid fly through multiple articles that have been published from multi-institutional registries looking at patients with hypoplastic left heart syndrome. Again, I flew through a lot of slides. If anybody wants copies of those slides, email me and I'll send them to you.
Jeff, thank you, Jeff. Before you take your slides off, could you please put the slide back up that had the 6-year difference between the RV to PA conduit and the Blay-Lactalsic shunt? I want to show people a point. That one, that's great. Sarah Tabbitt told me this recently, and I thought it was really interesting. And we're going to hear from David Brown and a couple of speakers. And your talk was just fantastic at setting up the next 2 sessions, Jeff.
Yeah, that was the goal.
That during this time period of the SVR trial, only one of the 14 centers, only one, Milwaukee, had an interstage monitoring program. And much of the death that occurred in this study, as you can see, was in the interstage period, which has been greatly reduced by the National Pediatric Cardiology Quality Improvement Collaborative. I think if this study was done again now, we would not have seen that difference early on. It's just a guess. It's a speculation. I wanted to put that out to everybody before I turn it on to Wes. And if I could ask you, thank you, Jeff. If I could ask you to stop your share so I can introduce my colleague in the cardiac ICU at Children's National, Dr. Wes Diddle. Let me just pull something up here. Wes, are you all set to go? Your slides ready to go?
They are, Gil.
Yeah, great. Thanks. So I asked Wes to do a very similar thing, but to look at a bunch of databases, and in particular, because this series and my interest is in perioperative care, what have we learned from the collection of databases about our current management strategies? I'll turn this over to you, Wes.
Thanks, Gil. Just pull my slides up for you. Everyone see that okay?
Perfect.
Great. Thank you for the opportunity, Gil, and the Congenital Heart Academy. We'll just take a quick run through a snapshot of what the life and outcomes are like for patients with hypoplastic left heart syndrome in the ICU. Thankfully, many of the sources that I pulled from for this talk were just referenced by Dr. Jacobs, giving me some external validity to what I'll put up here. I have no disclosures. So let's jump right into it with stage 1 outcomes. And I've listed across the top here a number of key resources for understanding the outcomes of patients around their stage 1 intervention. Mortality, in spite of the progress that's been made compared to X number of years ago when Gil started in this field, the mortality ranges anywhere from 8 to 15 or 16% across different databases. And certainly there's even more variability on the individual center level. There's also a lot of reintervention for these patients around the first stage operation. Unplanned interventions that might be operative, might be in the cath lab, but they're not insignificant, and they impact that mortality. The incidence of cardiac arrest across a number of registries after the stage 1 operation is somewhere in the teens, 10 to 20%. Again, somewhere between 10 and 20% of these patients will end up on ECMO during their stage 1 course. Not even taking into account longer term neurodevelopmental outcomes, just looking at the ICU level perioperative outcomes. And this is data that these numbers are surely not as representative as they truly will be as we do a better and better job of surveillance. But there's a not insignificant incidence of strokes, intracranial hemorrhage, and seizures, as well as neurologic deficits persisting at the time of discharge. Some patients will end up with significant renal injury, including being dependent on dialysis. Vocal cord injury, again, occurring in 10 to 20% of the cases. And then patients will leave the hospital dependent on some additional technologies. So at NPC-QIC, just over half will be eating all by mouth at a year of age. Looking at the SVR trial, about a third at the time of discharge were eating by mouth. The rest were dependent on some type of tube, whether that's a semi-permanent or a nasogastric tube. And another data set for looking at it is the FIS database, where Pradham and colleagues noted over a quarter of the patients after their stage 1 operation ended up with a permanent G-tube.
I just wanted to add one thing to that, Wes. It's perfect. I just read a manuscript that was looking at parental dissatisfaction during the hospitalization for the Norwood. And the number one thing was team communication that was poor. But the number two thing that was the most challenging for the moms was the presence of a gastrostomy tube. This is not a small factor. And I hope we have a chance to talk about that a little bit later. But as people can see, it's very institutional dependent, but we'll run between a quarter and a half of the babies with a lot of, it's not just the tube, it's what it does to the whole family.
Yeah, and I might argue that looking at across the range of these outcomes, part of the challenge is how we frame this from the get-go. If this is the numbers and the values that we're working with, how do we set families up with realistic expectations for what their child might encounter? And then finally, a median length of stay that by those numbers there means that at least half of children are spending more than a month in the hospital following their stage 1 outcome. And here in the middle, you can see that 13% will be staying all the way until their second stage. But even inside these numbers hides a lot of variability. And I think Dr. Jacobs was alluding to this. Some of the studies that have come out from the original SVR data set and then using things like PC4 and NPC-QIC have laid bare how much center-to-center variability is hidden behind these means and medians. There have been alternative strategies that have been developed. The hybrid used in fewer centers and in some centers as a primary strategy and in several centers as a strategy for a select subset of patients. And that select subset of patients is often higher risk, and that's reflected in the higher mortality numbers listed here, the higher rates of reintervention that are seen, higher rates of ECMO, and that median length of stay that you see there at the bottom. Some centers like Gießen, whose mortality is listed up there on the right, where the hybrid strategy has been the focus of their paradigm, have been able to get numbers down to very impressive levels. But it's not representative when taken as an aggregate of all performing centers. And again, the median length of stay there means that half of these patients are spending more than 2 months recovering from this operation. So how does the first stage of hypoplastic left heart syndrome look to a patient and to a family that's going through? Well, it's a marathon. It's not a sprint. And this first leg of the marathon is a doozy. The data is showing that we can get smaller, more complicated patients through this first stage than we could in years past, but that most will spend more than a month in the hospital. 1 out of every 8 will stay all the way until their second stage operation. A quarter will have some sort of technology dependence, at least in the near term. And then that there's significant variability that suggests that there is room for improvement. And as Dr. Jacobs mentioned, that's where a lot of the efforts are focused now. Glenn outcomes, obviously the numbers suggest a different perioperative experience. It's a Goldilocks of physiologies in some respects along this continuum. with much lower mortality, much lower cardiac arrest and ECMO rates, much lower neurologic incidence of neurologic sequelae, and a much shorter hospital length of stay. Some of those more challenging patients that are brought to this stage using a hybrid strategy, which again is often targeting a higher risk subset of the population. They get through their first operation, but then it has moved some of the higher risk aspects of the Norwood downstream. And so the comprehensive stage 2 outcomes reflect that with considerably higher mortality and reintervention rates. And finally, coming to the Fontan, where again, mortality is quite low. Unplanned reinterventions are lower, as are cardiac arrest and ECMO rates, much in a similar way to the perioperative numbers around the Glen, all adding up to, generally speaking, a smoother perioperative course like the Glen compared to the stage 1. But I think in aggregate, the ICU course for hypoplastic left heart syndrome is one that's labor, cost, and for families and staff, emotion intensive, primarily at the first stage operation, regardless of which type of shunt or pathway that you choose. I think a lot of improvements are happening, but in large part, those improvements are driven by reducing unwanted variation in practice and in improving the outcomes of some of the highest risk patients. And the stage 2 and 3 ICU courses are much smoother and generally more predictable than stage 1. But unfortunately for these patients, stage 3 is often not the last we'll see of them in the ICU. Thanks.
Very sobering, Wes, and very helpful. Thanks so much for putting that together. It was a lot of labor for just a few slides, and I think the audience and I really appreciate it. And I'm going to move from you, Wes. There'll be some questions, I'm sure, to another one of our colleagues here at Children's National in Washington, D.C., Shri Deshpande, who is the head of our heart failure and transplant program and many other things. He works in the ICU. And he's going to talk with us about transplantation. Shri.
Thank you, Gil, Sasha, Grace, for the opportunity. My goal today is to try and see how transplantation fits into this, what we would call a new model for hypoplastic left heart syndrome, which you'll hear a lot about in the later half. But then equally importantly, these are again just my thoughts in terms of how we need to change the conversation around transplantation, especially as it relates to hypoplastic left heart syndrome. So thank you again, CHA, for the opportunity. The first thing I want to start off with is this. We've heard in the SVR trial, one of the key endpoints, primary endpoint, was transplant-free survival. And right at the get-go, I want to challenge that by stating that we need to be talking about survival with transplant rather than transplant-free survival. And I'll tell you why that is important. This is the slide that we saw earlier from Dr. Jacobs. And what is noteworthy is exactly like I said, we are comparing death, free of death or transplantation. So in a sense, the conversation, starting with the cardiologist, starting with the fetal cardiologist, and then on to parents, is our conveyance of the goal that the survival needs to be free of death and free of transplantation, which is the optimal outcome of a hypoplastic left heart syndrome. And what I want to challenge is how can we change that conversation within ourselves first to change to survival with transplantation. Whether you do the transplantation or not, it doesn't matter. Where transplantation continues to be an option for us, because as we've already seen in the last two presentations, there is a significant interstage mortality, morbidity, and we need to recognize that transplant needs to be an interstage option, right? And so the problem with using transplant-free survival as a measure of outcome translates into practice, because what we want to then do is to keep these patients free of transplant as long as we can, because that we consider as a good outcome. And what we have recognized is that that may not necessarily be true. So does this mean that we have to change our goal of palliation? And goal here is as it relates to our quote unquote endpoints. And here I would recommend a thought process change where we talk about survival with transplantation. And I'll show you why that really is important, because that is our current practice. Our current practice is to treat transplantation as the fourth stage of hypoplastic palliation, right? Norwood Glen or hybrid Glen, and then Fontan. And when Fontan fails, fourth stage is transplantation. In doing so, what we think we are converting or creating are suboptimal Fontans. And Dr. Wellig already mentioned that why a lot of Fontans are suboptimal. What that translates into practice from cardiology standpoint is to delay and try everything until we quote unquote give up and talk about transplantation. Or what I refer to as normalization of a Fontan, which is daily living, quality of life, growth, as doing okay again and again. And we really need to challenge that doing okay is not okay enough for very critical growth phase of these kids. And the other concept or misconception still out there, both in the cardiology community as well as the patients, again, a lot of them learning from us, is that when these patients do go through transplantation, their outcomes are really poor. So again, hold off doing transplantation because the outcomes are really poor. And the data really does not support that anymore. However, when we do delay and we create the suboptimal Fontans, this is beautifully shown in this recent paper in JACC, where if we look at patients above 18 years of age that are coming for heart transplantation, look at the comorbidities that are accumulated in this picture. And what you see is that on one axis, on the y-axis, you have complication risks and pre-transplant mortality on the x-axis. And if you focus on the Fontan and the multi-organ failure with a Fontan cohort, they are at the highest risk of pre-transplant complications and at the highest risk of pre-transplant mortality. And as you guess, when these patients do get transplanted, their outcomes are suboptimal. So we are really setting up these patients for not succeeding at the Fontan stage. Let's look at this one more time. When we delay listing or delay referral for a transplant evaluation, this was our analysis a few years back now, looking at the UNOS data. What we found is shown up here, which is waitlist mortality in patients. And what you see is that early on, there is a clustering of waitlist mortality, right, after listing for a transplantation. So listing did not create that mortality. Obviously, these patients were very sick at the time of listing. Here is a hazard ratio of mortality post-listing. And what you see is that in the first 2 months, there is a huge spike in mortality during wait list for single ventricle patients. To me, what that tells us is by the time we are pulling out the transplant card, we have very sick patients on our hand. And therefore, it is no surprising that the outcomes were not very good for these patients post-transplantation compared to, say, a dilated cardiomyopathy. Transplantation survival, say at 10 years for a stage 1, stage 2, and stage 3 are shown here in the bottom pictures. The A shows overall survival. But there's a slight good news, which is that in the current era, at least, it does seem that the survival has significantly improved. And a lot of that has to do with post-operative care, not necessarily the pre-morbid condition for these patients. So we still haven't changed our behavior as far as timely referral for transplant evaluation is concerned, but maybe our transplantation and the care afterwards has improved in the last decade or so. The other thing people often talk about are these patients are then too sick to use bridge strategies. And as we have seen now, that when we bridge these patients with the devices, that their outcomes during the waitlist period is not really optimal. This is one paper out of Stanford. Again, we have single center studies looking at pre-Glen, Glen, and Fontan survivals. And as you can see here, that the Glens have the worst survival as bridge to transplantation with a VAD support compared to pre-Glenn or even Fontan. And Fontans with a ventricular failure actually do well with these with the assist device. So again, are these self-selected patients where VAD was done as a last-ditch effort to salvage these patients? That's possible because that's how we look at it. But again, cumulative experience is showing us that these patients can be salvaged really well. And the group from Gainesville, Florida has shown this in nicely too, which is that pre-palliation or post-palliation patients can be supported with devices now with a little bit of imagination and creative surgical approaches to their supports. And similarly to what Dr. Gil was saying, that timely consideration and optimization of the Fontan with a Fontan pump would be the best strategy to salvage some of these patients. And this is a series of work that we had put together. This is the last of the papers, again, looking at pump parameters that would be required to support a Fontan failure with a support on the Fontan side. So again, not ventricular support, but a true Fontan assist device or a FAD rather than a VAD. And that would be a pre-bottleneck pump because that would increase our output from the Fontan circuit itself and create better preload for the ventricle. So these are active strategies that we have to look at as options for these patients rather than just sitting on Fontans that are doing okay and waiting too long. What are our next options for these patients? Well, believe it or not, it's back to future. So we saw in the opening video mention about baby Faye, but very few people know about baby Moses. And baby Moses, that's Leonard Bailey, Dr. Bailey in the middle. Baby Moses was the transplant that was done literally a month after baby Faye. Baby Moses was a hypoplastic left heart baby and received a human heart this time, not a baboon heart. This was primary transplantation for hypoplastic left heart syndrome with reconstruction of the aorta, all done in the neonatal period. And baby Moses is the longest surviving primary transplant patient today. He is 36, 37 years old and functionally doing great. So we know that primary transplantation, it really can be very, very useful and have excellent quality of life. Obviously, as Dr. Jacob mentioned, the issue is the supply of organs. And to that end, the world is moving on back to xenotransplantation, back to, again, what Dr. Bailey did for baby Faye. And the research, this is a nice review current in 2020 in Circulation, which looks at progress towards cardiac xenotransplantation. And what we have recognized is that current genetic engineering has allowed us to create knockout models, especially pig models, that are much more compatible with xenotransplantation now. And our guess is that in the next 5 years, we would be in a place to start clinical trials for xenotransplantation. And this would open up a huge new area for palliation for our patients. So I am excited about that prospect and how well some of these transplants can do for us. So as Gil had mentioned, where does transplant fit in the current model? Stage 1, stage 2, stage 3. I don't think this is the linear approach is correct. The linear approach, actually what translates into practice is this, which is an incremental loss of patient survival over time. So it's not really linear, it's just the survival bias and a pyramidal approach, which I don't think is optimal either. So what transplant really needs to look at in the next decade is to look at this constellation model, where a baby that's born with a hypoplastic left heart syndrome would have options and get optimal options, could be a hybrid, could be Norwood, and at every single palliation mode, transplant continues to be a constellation, a star that you can reach out to, whether it's at stage 1, stage 2, stage 3, or primary. And when we adopt this strategy, an open-minded constellation approach rather than a linear thinking approach, then we'll be able to optimize these patients, optimize the survival of these patients with or without transplantation. So what is my plea to everybody who's listening in? One, improve palliation, obviously. Look at everything that you can improve on. Convert the conversation about transplantation from last resort to continued consideration. educate ourselves systematically how to better evaluate timely referral and optimize pre-transplant care of these patients. And then lastly, I really do think that VAD and xenotransplantation will completely change how we palliate some of these patients. And that's all I had, and I'll be happy to take questions. Thank you so much.
Shri, that was awesome. I love that. It brought up a couple of things to mind. I'm sure you've heard the term that xenotransplantation is the future of transplantation and always will be. But it does sound like we're getting a little bit closer to that. I'm going to go ahead, Shri. We're running over as we always tend to do.
I think so, Gil. And again, that circulation 2020 review is a phenomenal review at really where the state of art is. And when you get a circulation paper that talks about state of progress and state of art, that means we are making progress.
Good point. I'm going to turn over now to a colleague in Boston, Massachusetts, where I started my training, someone who's been really active at the National Pediatric Cardiology Quality Improvement Collaborative. His name is David Brown, a great cardiologist. And this has transformed how we do things. I remember the days of the single center answered questions, and there was competition between the centers and sometimes not the most collaborative competition. That paradigm has completely changed. And Dave, I'll let you explain that to everyone. Thanks.
Thank you so much. Are my slides showing up okay?
They absolutely are, Dave.
Great. Such a pleasure to join you. Thank you so much for the invitation. And I'll just spend a few minutes talking about the National Pediatric Cardiology Quality Improvement Collaborative. It's been referenced a couple of times already today, which I'm delighted to see. I'm just going to give you a very brief outline of the history and some of our progress. So this is, I like to show this slide because it's overwhelming. And this is a slide we showed the first time we came together at the first learning session NPCQIC had in September 2009. And for people that do quality improvement, this might look more familiar, but to most of the cardiologists, nurses, and parents in the audience, this was a brand new way to look at things and a new language to learn together. But on the left-hand side, you can see the aim of NPCQIC, which really was focused squarely in on interstage care. Can we improve survival and quality of life for babies between the first stage Norwood and bidirectional Glenn? And in the yellow, you can see these are the things we wanted to focus on as key drivers, how we're going to improve that outcome. And then over on the right-hand side, just various different change strategies we came up with as a group that we could pilot and see if we could actually drive that aim that we were looking at. So at the time, again, this was 2009, these are the 35 teams in the United States that came together at that first learning session. And at the time, a lot of centers, as Gil referenced earlier, didn't collaborate all that often on things. So we had to set up some ground rules for that collaboration, including everyone has a voice, that your variations in sharing of data will be respected in a confidential fashion, that when you're stuck, you'll ask each other for help, that people that show successes early, others can adopt rapidly. And there's this concept of share selflessly and steal shamelessly from each other. People's good ideas could disseminate really quickly and rapidly. And then really focused on this concept of all teaching, all learning together. So if you remember one slide from what I talk about today, this is the one to focus on. In 2006, this is sort of the tail end of the SVR trial Dr. Jacobs was referencing earlier. Interstage mortality at that time, 15 to 20% in the United States. Growth failure, which we haven't talked about as much, was there in 30% of these babies. And at that time, as I mentioned, there was a lot of little islands of care, but less of a community feel, at least among centers in the US. There was a lot of variation center to center, and home monitoring at that time was minimal. If you're a baby born today through the collaboration in our network, your outcomes are dramatically different. Interstage mortality is now 5% among participating centers. Growth failure is now down under 10%. And we've now grown to over 70 centers, and I'm delighted to say we're international now as well, with centers in Canada as well as the UK, and we welcome others if people are interested. We've got various different strategies we share, including interstage management, growth, nutrition. Through our registry, we've been able to identify new concepts such as the value of digoxin and interstage survival, and have developed tools such as a newer risk score to identify the highest of the high risk infants. And from that first phase, focused on the interstage, we sort of expanded in the second phase of NPC to survival and actually diagnosis to first birthday. So we've really been focused on a lot of different metrics, not so much survival, but also what's your quality of life? And for example, how many of those kids can actually eat their birthday cake at that first birthday? So currently, we've grown, as I mentioned, we've now got not just cardiologists and nurses, but surgeons, intensivists, fetal cardiologists, those focused on neurodevelopment, dietitians. We're also trying to look, as many are now, at disparities in health equity. We're trying to improve rates of feeding across the board, reduced unplanned reinterventions, really focus on neurodevelopment. And we've got some other nice pilot efforts on effective tube weaning and a surgical coaching initiative. Really important to note here that one of the amazing things about NPC is the collaboration with parents and now collaboration with patients. And I just wanted to show you, this is from a recent learning session we have. This slide demonstrates these are all parents and some patients as well who were there at that most recent learning session. So we had 225 clinicians in 2019, 76 parents and 35 patients. So it's an incredibly important part of the collaborative. And I just love this quote from Sarah Vinci, who's the mom of a child with HLHS. We can learn from one another and get better faster. And that really sums up what NPC tries to do. Some of you who have been to Manhattan may recognize the bronze statue on the left, the fearless girl, who for many years was facing down a bronze bull of Wall Street. She's now by herself as the bull has been moved. But on the right-hand side is fearless Zoe, who is 10 years old and has HLHS. And she's fearless as she's contemplating her future. And so looking forward, we feel like the next phase for NPC is really helping with what's now known as the Fontan Outcomes Network, or FON, which currently has been developed. There are now 12 centers involved in a pilot phase, and we're hoping to launch this year. So Fontan Outcomes Network really is a natural extension of what we've tried to do in NPC. It's dramatically improved quality of life and longevity for our patients with HLHS into adulthood. So it's focused on physical health, emotional health, and resilience, and neurodevelopment. And my last slide, just some context if people want to learn more. That was a really short intro. The various different sites are listed here on the slide, and I'll stop there.
David, that was awesome. I just put all of those in the chat box as well, so that people will have them. Your email inbox, I suspect, is going to have a lot of questions, and that review was really wonderful. Thanks. To think back to those days when we started, I remember sitting in the first meeting with the ACC, and it was, the notion was we should study hypoplastic left heart syndrome, and there was a lot of, why would we study that? It's such a small niche group of patients. But what's been fascinating is the extrapolation of the principles learned in HLHS to now other, not just HLHS and other single ventricle, but many other diseases. And you and the group really should be congratulated for just some amazing work. It's hard for me to know where to start introducing the next speaker. I have learned so much from Katie over the 2 decades. God, Katie, it's been a couple decades since we've known each other.
Yes, it has.
Katie started out as a bedside nurse and knows all too well the trauma of this whole process for the patients and families, and has gone about doing something about it. And now has been involved in, I think, the first dedicated network at a single institution. And she'll share with us what she's learned over the years, developing a structured and interdisciplinary follow-up. Katie, it's all yours. Thanks.
Thank you so much, Gil. Good morning, everyone. I think show.
I think the two buttons on the far left will help you down there. The one to the right of that one should advance it. Yep, that's what you get for listening to me. Okay, you're muted, Katie.
Got it. Why should we do this? I'll just do it this way. This is not a normal physiology. A Fontan doesn't create a fixed or corrected system. Dr. Fontan described it as an anatomical correction, where blue blood is routed to the lungs and pink blood to the body. We've just been learning about the tremendous inpatient and surgical focus, and we've done a phenomenal job of determining what the key drivers for survival are in our patients. But what happens after the Fontan? We have no defined or agreed upon routines or protocols. We have no stages. We have no script. We have no databases. We have no interdisciplinary team. But there should be. Because if we're going to improve survival and quality of life for our Fontan patients, we have to figure out what the key drivers are. Because all of us know there can be and there are significant challenges for these patients. And we know that this physiology impacts multiple other organ systems and that all of this is interconnected. And we also know that there is a tremendous burden on patients and families over time. What do we know? We know that our patients have a health condition that's persistent and long-lasting in nature. We know that this is a disease that lasts longer than 3 months. It can get worse over time. It may lead to death. It may cause permanent changes to the body, and it may impact quality of life. And this is the World Health Organization's definition of a chronic illness. And the mandate for chronic illness is to develop medical care that is patient-centered in medical homes. We have a responsibility to create a medical home for our Fontan patients, a responsibility to improve their outcomes and lifetime care for these patients. And we need to know what the key drivers are. This starts with the development of structured interdisciplinary teams that follow Fontan patients. We need to build expertise, knowledge, breadth, and depth. In 2011, over a decade ago, we started the Fontan Single Ventricle Survivorship Program at the Children's Hospital of Philadelphia. Our aim was to survey patients, evaluate them in a multidisciplinary clinic with a team of experts. We included liver doctor, endocrinologist, immunology, and we determined experts that we would consult if we needed to. The focus of this first program a decade ago was on the complications. Focus was on surveillance. We started with an illness model. And I can tell you that if you build something like this, patients will come. We have evaluated close to 600 patients over the past 10 years, and many have now returned for 2 to 5 follow-up visits with us. We've learned about the liver, lymphatic issues, growth, immune function. We've created a team of Fontan experts. We have depth, we have breadth, we have data, and we are learning more about what the key drivers are for survival. But what we found out along the way is that many of our patients, over 2/3 of the patients that have come through this program are well. In fact, some are actually rock stars. What we've learned is that surveillance is not the only key driver. And so in January 2019, we pivoted and we rebranded the program. This program is now the Fontan Forward program at CHOP. Fontan Rehabilitation, Wellness, Activity, Resilience, and Development Project, with a focus not just on surveillance for complications and problems, but a new focus on exercise, mental health, nutrition, and education. We started the program in January of 2019, and we added more people to the team. We added more clinics, and we included a psychologist, a dietitian, an exercise trainer, and a social worker who are committed to the program and part of the clinic. We've learned that there are opportunities. We can make the Fontan the best it can be for each patient. We can continue surveillance, but we need to pivot to a health and wellness model. We need to optimize tolerance of this physiology past 20 to 30 years. We know that for some patients that will be possible. We need to identify complications early and try to rescue failing Fontans. We need to develop a wellness assessment tool to assess wellness and disease burden. We need to promote a wellness lifestyle in our patients. We need to improve the scope, the depth, and the breadth of the team. And we need to collaborate because this effort is bigger than a single center. In 2019, the AHA published in circulation guidelines for the evaluation and management of the child and adult with a Fontan circulation. There are multiple centers across the country that have programs just like this, and the number continues to grow. Parents and patients are involved in this effort. There's an international Fontan interest group. The National Pediatric Cardiology Quality Improvement Collaborative is involved, and an outcome from that is the Fontan Outcomes Network, which David talked about previously, working towards the development of a national database and standardization of care and follow-up for these patients. And just on Thursday, they released a press release. The Fontan Outcomes Network is partnering with 12 care centers over the next year in a pilot program to establish and refine a longitudinal data registry, which will be the first step in the mission to optimize longevity and quality of life for our Fontan patients. 12 of the top care centers from across the country for individuals living with a Fontan circulation are part of the pilot. And these are the centers that we will start with. How can we move Fontan survivorship forward? We can be and need to be proactive. We need to screen. We need to confront challenges. We need to innovate. We need to collaborate. We need to find a way up and over the obstacles in front of us. We need to move forward. Thank you.
Wow. Katie, so much has happened over that time. I think that's absolutely just fantastic. I'm going to turn this over to Grace, and Katie is comes across quite modestly, but this national and international registry, quite honestly, would not have happened without your energy and passion. So thanks for doing that. And I'm sure the kids and their families, thank you. And it's been interesting. Our new surgeon, as you know, in DC, Aziz Dudicam, has been involved in this for a long time. And it's interesting to see a surgeon talking with the patients about the importance of exercise and diet, much more so than chest tubes and all that sort of stuff. So it's been a great addition to our program, and I really look forward to seeing the results that come from your great efforts. Grace, I'll turn this back over to you.
Okay, thank you, Gil. And
wait! I have to say something. I'm sorry.
Yes.
I get to interrupt. This is the last of this series for the so-called academic semester, and I just really want to thank Grace and Sasha Agati, who helped get this started. We couldn't have these sessions without the two of you, and I just wanted to give you a big public shout out for all the great work that you've done in starting the academy and keeping it going. So thanks.
Thank you, Gil. Thank you very much. It's something that comes from our heart. You need to know that we do this with all of our heart to spread education all over the world, and this is the best thing that can happen to us, is to be able to have you great speakers and to have this big partnership with Sasha and Gil to spread education. This is something that is awesome. I'm very happy for that. Thank you very much, Gil. So now we are going to have two very interesting things. First, we are going to have a PCICS talk. We're going to introduce you a little bit more about PCICS. And after that, we are going to have a poll from the audience. We want to know more about you guys. We want to know more about where are you from, what you're doing, and your thoughts and your practice. So I just typed on the Q&A chat box, no, on the chat box, a link for you to use for this poll. And I'm just going to show you very quickly a QR code. So please get this. Can you see this QR code?
You can open it up on your phone or another browser on your computer and allow you to go through the poll. And I will be doing that after you hear from Jill and Melissa.
Perfect.
You need to open it up in a separate browser window. Thanks.
So if you want to do from your phone, you scan this QR code. If you want to do this on your computer, you just click on the link that I just post, and then you're going to be able to do this either way. This is going to be very, very fun, and I hope all of you can participate on the poll. So now we have here as a panelist today Jill Zender, who is from the board of directors from PCICS. Thank you, Jill, for participating. And we have Melissa Jones as well. Melissa is going to talk a little bit about PCICS. Melissa is a cardiac critical care nurse practitioner, and she's the president of PCICS. Thank you very much, Melissa.
Okay, you can hear me and I will start.
Perfect.
Okay, you can see the slides.
Yeah, they just need to go into presenter mode. That's perfect. They come up fine.
Okay, great. So thank you so much to Grace and Sasha and Gil for this opportunity to talk about PCICS. This is such a wonderful collaboration. It's a real win-win for our society, and we're really grateful for this partnership. We recently revisited our vision and mission statement for PCICS last fall. So our vision is connection strengthened, care transformed, outcomes elevated, and lives enriched. Our mission is to empower a diverse global community of pediatric cardiac care clinicians dedicated to improving the lives of patients and their families. There are several ways to become involved in PCICS. We have several committees as are listed here. Our newer committees are Diversity, Equity, and Inclusion Committee and our Finance Committee. And then our special interest groups are less formal sort of groups that allow for networking and community building. They're very popular, and we are looking to expand them even more to other disciplines so that we can better represent the full team that takes care of patients in the cardiac intensive care unit. What I think is the most sort of unique thing about PCICS is part of our structure changed under the leadership of Peter Lawson. And at that time, when he was president, he changed our bylaws so that the mix of the board was 50% nursing and 50% physicians. And we rotate our presidency, so between nurses and physicians. The other thing is that whole structure permeates down through the whole society. And so the committees are formed in such a way that the co-chairs are a nurse and a physician. Our meeting is developed in a very interdisciplinary format. And so it really allows for important collaboration. Some of the resources that are available on our website are the nursing guidelines, and there are defect-specific guidelines, there's nursing practice guidelines, and these are valuable and accessible easily at the bedside. So I encourage anybody to use them. They're particularly relevant for educating new staff. You know, if you're about to admit a AV canal patient from the operating room, you could quickly pull up a 2 or 3 page summary of what to expect. We have podcasts. We have a huge library now of really wonderful podcasts. They're available on iTunes and Spotify, and we have a quarterly newsletter. Our publications and courses are really expanding quite a bit. So the advanced practice provider curriculum and course is very popular. We'll have 2 of them this year. We're in the process of revising our 2nd edition of the handbook. And we have a 4th year fellow curriculum that's available in both English and Spanish. Our CICU nurse curriculum is coming soon, and we'll hopefully be developing a course to go along with that. So that will be by the fall. Some other sort of membership benefits include some discounts. As I mentioned, there's a lot of networking opportunities. We have discussion boards. There's access to our membership directory and free job postings. And I would encourage you to come to our website to look at our meeting details. It will be virtual this year. It'll be the beginning of our celebration of 25 years, where we plan to continue that celebration in Miami in 2022 when we can all actually be in person. But I would encourage you to check out the website to look for details about the meeting. It'll be September 20th to the 22nd. And as I said, it's all virtual. So I'll just close by saying that PCICS for me has been more than a meeting to go to. It's really become a professional home, and I've found a community of colleagues and friends that I am very forever grateful to have. So I invite you to find a place within PCICS that suits your role and suits your career. I'm happy to answer any questions or email me with any questions.
Alyssa and Jill, I was wondering if I could just ask you both a question while you're on. That's both a little bit self-serving for the academy as well as for the society. I suspect that there is a disconnect between the way some of our centers have collaborative practice between physicians and nurses and integrate through the PCICS. And many centers in the US, and then in particular, as you know, our audience is international, where this is very different. How do we engage nursing in a collaborative fashion to things like the academy and the PCICS? What is the impetus for them to join?
You know, it always comes back to finding meaning in your profession and your work. And so to me, I feel like the hook is not necessarily a particular session, but it's finding meaning and passion in the work that you do every day, such that you are compelled to you're compelled to come up with questions and seek additional education or mentors around that. And I think that's how people will be drawn to CHA or PCICS or NPCQIC, like any of the sort of professional development opportunities.
And I think to add to that, although we've created the space and we want nursing involvement and engagement, I don't think that we have invited or made them feel like there is a space. So now the space is created, I think we have to just work to make them feel welcome and comfortable in the space.
As you'll see when we do the audience poll, most of this type of information that we're sharing today is not picked up by, is not picked up by social media, interestingly, but emails and word of mouth. So once we finish the poll, I may come back to you and ask you how we can do a better job. Okay.
That sounds great.
All right, Grace, I'll bring it over to you.
Very nice. Thank you, Melissa. Thank you very much. And PCICS is really a good part of our life on the CICU. I was on the connection committee for 3 years. I had so much fun with that. It was really, really amazing. And I really miss the meetings. Hopefully next year. Hopefully next year. Thank you very much for letting me participate in all of that. So now we are going to have the pool of the audience with Gil. I know Gil doesn't need any introduction, but I'm always happy to say that he is a senior consultant at Children's National. First time I saw him was there when I went to visit maybe 3 years ago. And he's doing a great job with Congenital Heart Academy. And we are very, very thankful to everything that he's been doing to us. So with you, Gil.
Thank you. I'm quite sure I get more out of the academy than I put in. This has been just one of the highlights of my professional career. And who would have guessed it that it came out of a pandemic? So I encourage people to either type in another browser window, ahslides.com/HLHS change, or you can scan that QR code with your phone. These are fun. We have about a third of the audience right now, and I would, it's anonymous, so don't worry, there's no wrong answers, but it just gives us an idea of where the audience is with this. And, you know, one of the challenges we have in the Zoom era is not being able to stand on the podium and interact with our colleagues as well. And certainly know what the audience is thinking and wants to ask. So this is an opportunity for that. So I'm just going to, I see that people are logging in right now. I want to wait just another minute. It's probably worthwhile saying that we'll probably go over the top of the hour. We have a little more than an hour and a half of material left. So if people are willing to stay, we're willing. And I'm certainly willing to go on to keep this as long as people would like. All right, so we're going to get this started. That's this one here. So here's that first question. Jill, this is the one I was talking to you about. How did you learn about this webinar? How can we maybe improve what we do? I'll tell you, historically, when we've asked this question, social media has been less than 10%. So you should be able to click on one of these options. I think you have the option to click on more than one. As well, the LinkedIn stuff is working. I've been, I think I post too much on LinkedIn, but it's nice to see that that's coming up. We almost have everybody. At the end of entering this will go a lot quicker, as you'll see. And I will send this both to the CHA Academy, to CNOC, and to the PCICS, so that we can get an idea of how we can improve spreading the word of this. Okay, the next question, just at the bottom, say advance to the next slide, and we'll get an idea of the scope of almost a half of the audience here. Dr. Sands, who's going to be speaking next from the neurodevelopmental perspective, asked me to add that neurodevelopment therapist stuff at the end. Therapist stuff, I apologize. Those clinicians. And although we advertised this through CNOC, it doesn't look like we got a huge entry here. So we clearly have work to go with that. And I think we clearly have room to go with getting nurses involved in the academy. Jill, I think you and Melissa and Katie, I'm going to be tapping you to figure out a way to do a better job with that. We're going to advance to the next slide. But clearly the majority of the people on here are the people who look after babies with HLHS: cardiologists, surgeons, intensivists, advanced practice nurse. Where is our audience from? All right, so this started in the afternoon in the UK. In Asia, it's dinner time. In Australia, it's like 11 o'clock in the morning. And I guess Joe Biden and Vladimir Putin haven't gotten enough détente for us to get any of the Russian former Balkan states. But we have a nice spread of people from all around the world. We're trying to figure out for a couple of reasons. One is 10 o'clock in the US covers just about the globe. And as we plan the World Congress, of which both the Cardiac Intensive Care Society and the Neurodevelopmental Society will be embedded, as we plan live webinars, we have to find the best day and the best time. And I decided not to ask the question, do you like webinars on a Saturday? Because you're here on a Saturday. It's the classic example of bias. I want to know why the people didn't come on a Saturday. Okay, this is just a question about the trauma of the Norwood procedure and all the stuff that goes around that for the patients and their families. Do you have developmental care practices like is common in neonatal intensive care to take care of neonates with hypoplastic left heart syndrome? And you can do more than one here. And I should have put we have none on there because that would have been interesting to see. Well, we've made progress over the years, but I think there's still opportunity to to move forward. It's Melissa, I'm sure you'll relate to this. The notion that the baby with a Norwood operation, for example, is so fragile you can't touch them needs to be rethought. And you can see the holding policy is only roughly 1 in 6 of the people who've answered this poll. So maybe we can talk about that as we move to the end. But it's good to see so many people having multidisciplinary care progressive rounds. Okay, I'm going to move to the next slide. Please hit advance. This is a word cloud. Tell me the most favorite part of your work. These are fun. No one has a favorite part of their work. I guess they're coming in now. Okay, here we go. Fix the heart. That's probably our 6 surgeons that have logged on. But we see what stays in the middle of this, and that's the team. Darren Klugman, I heard this first from, I don't know if he's the one who said it first, but CICU is the ultimate team sport. And I think that that's true. Very, very interesting. No one here put overnight shifts. I don't see that on there. Okay. Lots of great things there. Okay, I'm going to move to the next one. This ought to be interesting. What word comes to your mind? And it's 2021, and I think the words I chose in 1990 would probably be very different than the words I used to. So how do I feel if somebody gets the diagnosis, or I'm going to go talk with a family about the diagnosis of hypoplastic left heart syndrome? What kind of words come to mind? Heartbreaking, which is one of the first ones that popped up there, is interesting, and maybe we'll have a chance to talk about that. I used the same question in a webinar I did recently with Little Heart Matters, which are it was about 60 parents and a couple of patients with HLHS. Much more positive words than I'm seeing here, which is an interesting comment on the way we look at things and the way families look at the hand they've been dealt, so to speak. I think we may have to write that one up. I find this just totally fascinating. It's the first time I've asked a group of practitioners. There's some optimism in there. Okay, so a couple more. This is a new type of slide from this company. I don't know if it's going to work, but how old are you? All right, so 1 is less than 30, 5 is greater than 61, and these are 10-year increments. So we have an audience that is skewed toward 30 to 40, it looks like. Excellent. Well, that slide sort of worked okay. We'll see. Okay. So the average is still, let me see, less than 30, 30 to 40, 40 to 50. We're sitting around 30 to 50 for most of us. So all the speakers, you can imagine the audience now is between 30 and 50. And we generally have roughly 60% female on the calls and on the webinars. I would have, I know, Melissa, you have like a whole bunch of baseball games to go to this afternoon. So it's great to see the ratio is about the same here. Okay, I'm going to get to the next one. Okay, at my institution or location, the preferred approach to an otherwise uncomplicated baby with hypoplastic left heart syndrome is. All right, we've had 30, 40, 50 responses. Interesting. And then you could have our approach, which at Children's National, which right now is sort of what day of the week is it? I say that with tongue in cheek, but hopefully by the end of the session, we will we'll come to some ideas of what our next approach would be. So basically 1 in 8 of our attendees don't treat babies with HLHS. I'm really happy you joined us because the lessons learned here certainly can be applied to other types of complex congenital heart lesions. Are you a member of the Cardiac Neurodevelopmental Outcome Collaborative? And there is the link to join. Jackie will tell us next a little bit about the collaborative and what we do. And again, it's looking like, I'm just going to look at our agenda here. It's going to look like we're going to be going about 30 minutes late, so I hope that people can stay. I think there's one more, if I'm correct. I forgot to erase the old data. Who is, are you a member of PCICS? After your pitch, Melissa, I can't imagine anybody doesn't want to join, but we shall see. All right, we have many people who I think will benefit from this. This is combining data from our last combined PCICS, Cardiac Neurodevelopmental Outcome Collaborative, Congenital Heart Academy webinar. This is the future for children with HLHS. What best describes your view of, love that, view of the future for children with hypoplastic left heart syndrome? Sheree, we haven't gotten xenotransplant yet, but oh, you got transplant. That's good. And I think, I hope that we've done our job with, it's truly amazing. You know, this was a universally lethal condition 4 to 5 decades ago. And the fact that we're talking about collaborating pregnancies, children with this becoming fathers and mothers, and as you'll see later on, some amazing outcomes, as Katie likes to call them, rock stars. And I agree, this is a whole new world. It's really wonderful to see how things have come over time. And that was the last one I have there. I'm going to give it about 10 more seconds. While that's going up there, I'm pleased to introduce my colleague from Children's National, Dr. Jackie Sands. Jackie is a neuropsychologist who works in our outpatient CAN-DO program, which I'm sure she'll describe a little bit, and has had the, you know, after the great work done by bedside nurses, surgeons, cardiologists, intensivists, et cetera, anesthesia, we now have enough survivors to begin learning how they're doing, which is the part of the, which is what we're going to spend the next little bit of time talking about. Jackie's going to first talk about the Cardiac Neurodevelopmental Outcome Collaborative, and then we'll move from there to find out how the patients are doing. Jackie.
Hi, thank you all for having me here. Can you hear me okay? Did I turn my sound on correctly?
You're perfect. Yep, you just
Okay.
need presentation. You just need presentation.
There we go. I need to get a couple of these windows out of the way. Okay.
Perfect.
So I'd like to introduce everyone to the Cardiac Neurodevelopmental Outcome Collaborative. I was the first elected co-chair along with Brad Marino. I forget how many years it's been now. It's probably been 5 or 6 years now. And I'm currently the PI for the Neurodevelopmental Core Lab. And we work to ensure the fidelity and accuracy of the data in the registry, which I'll describe in a minute. So first, to describe who we are, our vision is we are a multi-center, multinational, multidisciplinary, lots of multis, an inclusive group of healthcare professionals committed to working together and partnering with families to optimize neurodevelopmental outcomes for individuals with pediatric and congenital heart disease through clinical, quality, and research initiatives, intending to maximize quality of life for every individual across the lifespan. And our mission is to determine and implement best practices of neurodevelopmental services for every individual with pediatric and congenital heart disease and their families through clinical quality improvement and research initiatives. So we're a very, like I said, multidisciplinary collaborative group. We draw from our member institutions. At its heart, we have a steering committee that's composed of our executive committee, the chairs, treasurer, co-chair, secretary, as well as the chairs of each of our standing committees that each have different goals to achieve within the organization. So we do have database and research committees that work on the database, the registry, which I'll describe in a moment, and research initiatives, program and meeting committee that works on our meeting every year, outreach, which is working with families, quality improvement, Publications Committee, and Education and Training Committee, which provides webinars such as this one, but also education and training opportunities for individuals in the institutions. We, in May of 2019, launched our clinical registry. It launched as a module of the PC4 registry. So we are able to tie neurodevelopmental data back to some of these surgical variables. And this is a partnership with various components of CNOC, Arbormetrics, and the Data Coordinating Center at University of Michigan. We are the Neurodevelopmental Core, and the Data Analysis Core is in Boston currently. And we have at this moment about 2,600 visits or assessments that are entered in the registry. I put visits or assessments because with COVID, I think some sites have been able to return to in-person testing. Some sites have had interruptions in that, but they've still logged telehealth visits. So we are working towards our first research aims using that registry data. I encourage everybody to explore and potentially have their institution join our collaborative. Gil has posted the website there. And also to think about exploring our 10th annual scientific sessions, which are going to be brought to you virtually in November. And I'm happy to take questions about the collaborative at any point. Let me see if I can switch slide decks at this point. It's a little frozen, give me a moment, and I'll go into the next portion to talk a little bit about neurodevelopmental outcomes in congenital heart disease. Oops. One more moment. All right, are those slides coming across okay? Can everyone see those?
Yes, perfect.
Okay, thank you. All right. So I'm going to talk a little bit at a very, very zoomed out level about what we know about neurodevelopmental outcomes in congenital heart disease and where we need to go in the future. I'm really going to describe this at a very high level, understanding that probably the majority of individuals on this call don't want to go into really specific data about neurodevelopmental outcomes. Really key points about what we know if we try to synthesize the literature that's out there. There's a very large range of outcomes, and this includes normal outcomes for some of our kids. In infants and toddlers, there are frequent delays in cognitive, language, and motor development, and probably the most common concerns are with motor development at that point. And as we move into preschool, school age, adolescence, young adulthood, we see increasing concerns in several domains. Probably the most prominent of these is with attention and executive function. Executive function, for those who are not familiar, is a set of skills that is not so much the know-how, but the how you do, how you execute skills. So this includes skills such as planning and organization, inhibiting your first response, working memory or your ability to hold information in mind as you work with it, remaining flexible in your problem solving. And all of these component skills really help you be efficient with your problem solving, help you learn. We continue to see issues around motor skills and then visually based skills, visual spatial skills, visual motor control, which affects students' handwriting. We'll see concerns with memory. We see concerns also with higher order language. So not just your vocabulary, but how you use language to communicate and with social skills. In terms of diagnostic information, we see increased rates of diagnosis of ADHD, and in single ventricle patients, that seems to be quite common. Up to half of those patients in some estimates have a diagnosis of ADHD. If you look at the group of congenital heart disease as a whole, the estimates can range anywhere from 30 to 50%. And comparing that to a prevalence in the general population of about 7 to 10%, that's quite a bit higher. And there's a very large increase also in diagnosis of autism spectrum disorder, as well as anxiety and a few other conditions. Looking ahead, however, I think one of the things that we need to acknowledge in terms of neurodevelopmental outcomes is that there is no unitary signature. There's no one profile or constellation of issues that we're looking at. And I think, specific to this seminar, there's also likely not a unitary signature for each specific cardiac diagnosis as well. So we know that in a lot of the studies,
Those with hypoplastic left heart, for example, do more poorly on measures of intellectual function by a bit. But there's some other presentations that have been done that show that if you control for variables associated with the complexity of the surgical course or the complexity of the disease, that sort of explains the difference, that the hypoplasts just tend to be more complex. What we need to, I think, better understand is how the individual features of these profiles or outcomes work as a dynamic network. So how do we see this as a network of risk factors, from components of the cardiac diagnosis to individual and demographic factors, surgical factors and other complications, to resilience factors, what helps people do better? Why do some children do very, very well that we wouldn't expect to do as well neurocognitively? And then how these relate to those neurodevelopmental symptoms. So this really encourages, this idea is to really encourage folks to think beyond DSM diagnoses like ADHD or learning disabilities and really look at this as a constellation of symptoms and how they relate to the various risk factors. We also need to understand that children may grow into the deficits that we see, and that these issues, particularly those around attention and executive skills or social skills, may occur even in the absence of earlier developmental delays, or even if they outgrow these early delays. So it is very common for a child to present with pretty typical meeting early developmental milestones, or maybe with some mild motor delays, but they receive some therapies and outgrow that. But they do present with different issues later on in the course of their development. So this is important because neurodevelopmental follow-up needs to occur across the course of a child's development, even if previous evaluations were normal. And we need to provide some anticipatory guidance for parents and families on what kinds of issues they should be looking at in different stages of development. And in an infant, you might talk to them about motor milestones, feeding, and speech. But for a preschooler getting ready to go into kindergarten, you're going to be talking more about looking for issues around attention, self-regulation, and social functioning. And that's to say that the focus of the evaluation is likely going to change over time. The kinds of things you look for are going to depend on those expectations being placed on the child at that time. This leads into a bit of the next point, which is this is not a static profile. Development is complex and messy. And we don't really have a lot of data on whether or not there is a developmental cascade or how this profile evolves over time or longitudinally. So understanding how earlier delays might then lead into some of these later concerns that we see is critically important, because it'll help inform how we can intervene to potentially interrupt this cascade, not just how the earlier developmental factors play into later developmental factors, but how some of those other earlier medical risk factors, demographic factors, and socioeconomic factors can play into later neurocognitive deficits. And also, which problems are most relevant to a patient's overall functioning. Probably the bulk of research that's out there, particularly that research comparing, for example, hypoplastic left heart to other forms of congenital heart diseases around IQ. But is that really the most important thing to how a patient does in their life or to the patient's quality of life? And in fact, it's probably not. There's a lot of evidence that other skills, particularly executive function, is a key predictor of quality of life, of academic achievement and academic success, and of mental health. And we know from other medical populations, there's a lot of work on this in spina bifida and other neurodevelopmental conditions, that executive functioning is a very important predictor of medical complications down the line, because it predicts how well an individual can follow through with needed care. So this is a very important skill, and we need to shift research away from just looking at overall adaptive function or overall IQ to more specific neurodevelopmental concerns that are really functionally relevant. And we need to know how other variables relate then to day-to-day functioning, differences in IQ, differences in visual skills. How does this relate to a patient's day-to-day life? The other thing that's critically important for us is, have we really characterized outcomes for all individuals with CHD? Our current research samples are not representative necessarily of our demographics, particularly here in the United States, and I suspect that that's the case also globally. We are looking at a really limited sample of our patients that can participate in this testing, and our ability to do neurodevelopmental evaluations in a very standardized way, cross-culturally, and across different, socioeconomic statuses and across global lines is somewhat limited. And so we need to better understand how factors such as culture, socioeconomic status, racial and ethnic, and health disparities influence outcomes in children with congenital heart disease. So I hope that provides just a nice little overview of what we know, but also of where we need to go and what we need to better understand to really move the needle.
Jackie, thanks. That was a terrific overview of tons of research into just a few slides. And I'm sure that if people take a look at the references from the papers that were just published, including the updates in cardiology in the young, we've, as you know, we've recently published the recommended studies to do that anybody can do with their teams in their own programs. I'm really happy to
Hey, Gil,
introduce.
can I just add that there's going to be a series over the course of this year of 7 CNOC manuscripts within cardiology in the young, including the one that's related to this presentation. It's a really important contribution, and they're featured on the Cardiology in the Young webpage in a special CNOC collection. So if one goes to the Cardiology in the Young webpage and goes to collections under CNOC, all these articles are cohorted together. It's an important contribution and really demonstrates the important leadership from CNOC.
Thanks, Jeff, as editor-in-chief of Cardiology in the Young. I appreciate you putting that in, and what you've done with the journal has just been phenomenal. So thanks.
Yeah, we have a good team. You're on the editor. You're one of the members of the editorial board, and we have a good editorial board membership, including you.
I need to put that on my disclosure.
There you go.
I'm really happy to introduce Frank Casey. I first read a lot of Frank's work before I had a chance to meet him through CNOC. And one of the most modifiable things that we can do is not in the ICU. It's not even in the operating room, but it's in the outpatient department. And it's not just what Katie was talking about, which is crucial, which is improving the physical well-being, but also the mental well-being. So Frank's work was 10 years ahead of its time. And Frank, thanks for sharing it with us today.
Thank you very much, Gil. And first of all, thank you for the invitation. I'm truly amazed by the initiative that you've undertaken with your colleagues, and honored to be a part of it. I hope you can see the first slide. The topic is really looking at how the patients, parents, and families are doing in the activities of daily living, and I guess that's the crucial outcome measure for all congenital heart disease. As a bit of, I suppose, a bit of lightness, when I first became interested in neurodevelopmental outcome and quality of life outcome as a young pediatric cardiologist, I came across this quote, and I think it describes very eloquently really what we're doing. The last sentence in particular, what kind of life are we offering to these blue and breathless mites snatched from the jaws of death? And
is there a way you can say that in Bob Anderson's booming voice? That would be perfect.
I wouldn't even try. I thought for a pathologist it was quite an insightful quote, though. But with hypoplastic left heart of all lesions, it's really relevant to that. So that's what we're focused on. Jackie has really eloquently, described the phenotype of children with congenital heart disease, particularly with hypoplastic left heart, and highlighted the changing neurodevelopmental picture from early infancy, where motor difficulties are perhaps more prominent, to the later phenotype with completion of tasks, executive functioning. But there are many publications, but I thought to try and crystallize what we're talking about. This is one, I think, very good paper in looking at the neurodevelopmental outcome of children with hypoplastic left heart. I suppose the first thing to say is that I am always an optimist. I suppose one of the most amazing things is that the children with such an abnormal circulation, right from in utero with abnormal brain perfusion to all of the complex surgeries, that so many actually do so well. If you look at the median cognitive performance, it's within normal limits. But we do have to recognize that particularly with very complex disease like this, there is neurodevelopmental impairment in a quarter of these children in a major way, and more minor neurodevelopmental impairment in almost half of the children. I think that when you look at the statistics, I know in the UK, about 40% of children with complex heart disease have educational support in school. And that's really crucial that I suppose what I'm focused on is the intervention to deal with the issues as we see them. Way back, a good few years ago, back in 2009, we started to look at things a bit more closely in our unit in Belfast. And before we started the CHIP project, which I will come to in a little while, we tried to look at the predictors of psychological function in mothers and fathers of infants born with severe congenital heart disease. Because whatever way we look at the birth of a baby with hypoplastic left heart syndrome or other complex heart disease, it is a life-changing event for not just the patient, but for the family, for the siblings. And what we have to do as a team looking after these patients is to try and ensure that that journey for them is not necessarily a negative journey for anyone. But what we saw whenever we looked at our population of mothers who were involved with us in the CHIP project was, not surprisingly, that 1/3 of mothers and almost 1/5 of fathers experienced elevated levels of psychological stress. Interestingly, in our work, the maternal distress was not necessarily, didn't necessarily correlate with disease factors, with severity of disease, but the mental health impact was really predicted by 3 parameters at the bottom as they're listed there, looking at maternal coping skills, their understanding of the diagnosis, and relevant information to their particular child is key in all of this. And then the family functioning, looking at the cohesiveness of the family. So at that time, we as a group in our department decided to look to see what we could do. Could we put together an initiative that might bring together all of the disciplines to see if we could modify in any way the stress that these families were going through? Could we modify, in fact, the outcome for the baby as a result of that? Because there's a lot of literature going back a long time that will confirm that one of the biggest impacts on the outcome of the child is how the parental structure and copes with that birth of that child and the care of that child and how they view things going forward. So I suppose our key message in all of this was that to get involved early with all of the support, the psychoeducation would benefit. And so we put together a team. The team included the pediatric cardiologists, the clinical psychologists, the nurse specialists, the speech and language therapists, dietitians, and a profession that we call in the UK and Ireland occupational therapists. What did it consist of? Well, it really, I suppose, first of all, to say it was a randomized controlled trial where half of the patients randomly achieved and were able to avail of this increased package of input, if you like. It involved us constructing DVDs which were really documenting visually the experience of other families, which was a very powerful tool. Our psychologists coached the parents in how to deal with problem prevention, psychoeducation with tailor-made information to the parents on their particular child, exposure to the medical equipment and a detailed explanation of all of that. So we mentioned earlier the crucial aspects around feeding and neurodevelopmental stimulation in the early period. And this was all in the first 3 months of life. Problem prevention therapy in terms of family adjustment. And then we provided the community health professionals when the children went home from hospital with detailed specific information on the specific needs of the particular child. The time is brief, so it's just to try and give you a headline view of what we published, and I'm happy to share the references with the audience, obviously. But what we find over a 1-year period was that by intervening with a structured program very early on, that we were able to improve maternal mental health, reduced their worry and consequent reduced demands on the health service. The patients and parents in the intervention group did demonstrate improved coping skills. Interestingly, we at 6 months with the Bailey's assessment, there was some evidence, and it did reach statistical significance of increased social and emotional development of the child at that time. There was statistically significant reduction in family stress. We saw some evidence for reduced feeding difficulties that didn't quite reach statistical significance, and also improved behavioral adjustment. So the task and the challenge is to maintain that over time. I'm happy to say that we now have got a structure in place that implements much of what we did at that time. I would be happy to share with you in the future the findings of the cohort as we are following them. And now, in fact, the first cohort are now reaching the stage where they're transitioning to the adult congenital heart disease service. And so I suppose my message is that the initial encounters and how the diagnosis of hypoplastic left heart syndrome and the potential outcomes for it are really crucial. And I've been in pediatric cardiology now for quite a long time, and over the course of my career, what I've seen is that that counseling and the early encounter has now shifted back very much from the newborn period to fetal cardiology and fetal diagnosis, and it would be really useful to have a fetal cardiologist give their view on this as well. I suppose the other thing that's changed that I've seen over the course of my career is that I and others have now started to include giving a more balanced outcome in terms of not just the physical outcome for the patient and their families, but to be honest and upfront about potentially the developmental issues, the neurodevelopmental challenges that lie ahead with complex congenital heart disease. And that's quite a difficult thing, as Jackie was saying, because it's not uniform. We see many high achieving patients with single ventricle, but I suppose we have to take the statistical knowledge that we have in looking at the whole cohort. I think what our work has shown is that, as Gil alluded to, that we've seen huge changes in surgical techniques and intensive care, but the developmental outcomes have remained fairly stubborn in terms of their status, and that if we are to improve outcomes, it's likely that that intervention is likely to occur outside of the operating room and indeed outside of the intensive care. And I would, I suppose, suggest that that first time from diagnosis to the first few months of life is really crucial to how that child and family will do in the long term. And so I would make the case for interventional programs being structured that can and that they will positively impact on the overall outcome for the children. So that's, I suppose, a very brief overview of a very complex issue, but I'm happy to take questions online or later. And thank you for giving me the opportunity to share this with you.
Awesome as usual, Frank. Thank you. Again, I'll ask people to put questions in the Q&A box. And I'll before I turn to the next speaker, I just wanted to mention some of the work that you did was some of the first work I looked at, not just reporting the outcomes, but trying to change them. And I think what I saw in one of your papers was, although about 3 to 5% of variance in outcome scores is related to what happens in the operating room, about 6 to 7 times that is related to maternal mental health and maternal well-being. So it's such a target for modifiable outcomes that I think we can't avoid doing it anymore. So thanks for bringing that to light for everyone today.
Thank you, Gil. Thank you.
We stop sharing there, and then I'm happy to introduce a new person to this whole process from Minnesota. And again, like many of the people that I've talked about today, it started with me reading just wonderful papers and wonderful work, and a recent collaboration between St. Catherine University in St. Paul, Minnesota, and the Mayo Clinic was published, and I contacted Katie Campbell, who was kind enough to share that she would be able to talk for 5 or so minutes about the work that she did. So Katie, I hope that this has been down, that you've enjoyed what you've heard up until now, and I look forward to what you have to say.
Gil, for the invitation, and yes, this has been incredibly an enjoyable morning, and I'm happy for the opportunity to share this work that was led by, I'll point out, 2 undergraduate nursing students at St. Kate's. And for those of you who are unfamiliar with St. Catherine University, we're a college for women located in St. Paul, Minnesota, really focused on undergraduate nursing education as a core component of our undergraduate body. So the paper that we recently published in Cardiology in the Young is titled Identifying Gaps in Parental Support for Families of Children with Hypoplastic Left Heart Syndrome. And as Gil mentioned, this work was done in collaboration with Mayo Clinic. I'll be brief since I'm cognizant we're running short on time. The design and methods of this paper were mixed methods in design, and it started with an exploratory qualitative phase where we interviewed mothers of HLHS children along with members of the interprofessional care team. And then from that work, developed a series of gaps in parental support that we wanted to validate with a quantitative survey, of which we got 690 parental responses from that phase. So I'll highlight some of the results here. I know there's a lot of small words on this slide, so I'll elevate some of the key concepts. Not surprisingly, we identified many gaps in parental support across the timeline of the HLHS child's journey. Starting from prenatal diagnosis, we did have a small focus on mothers who selected perinatal hospice for their infant, and so we had some really critical feedback from that subpopulation, as well as a majority focus on the surgical intervention timeline. Highlighted here are some of the key observations from both mothers and the interprofessional care team, and color-coded, which is not labeled in a key, are the 3 key themes that we identified. The first being unclear interprofessional team roles. The mothers weren't clear on who to go to for what support for their child or their family. Unrealistic parental expectations that really spanned the entire journey from early time in the hospital through their child's anticipated adulthood, and a lack of open communication between the family and the care team at different stages in the journey. So we wanted to validate these qualitative findings with a survey, and we had a large response, primarily mothers of these children, again, primarily from the United States, but we did have some international responses based on the IP address from this online survey. I want to point out we can't interpret where the child's care was received. This was based on time of survey response. We did have a majority of the respondents whose children were diagnosed before birth, but we had 25% whose children were diagnosed with HLHS postnatally. Majority of those parents selected surgical intervention, and a handful, 40 parents, did select perinatal hospice for their child. Majority of the children were living in this population. Some were deceased, and of those who selected surgical intervention, slightly over half had gone through all 3 of those palliative surgeries. And then again, we had a spread in the age of the HLHS patient from some mothers of in utero patients and families of children or adults over the age of 20. From this, we got some interesting feedback on specific prompts related to parental support. I'll start with the positive. We had strong agreement by and large with these prompts. However, you'll note that the y-axis is survey responses. So these are hundreds of parents who disagreed, either disagree or strongly disagreed with the statement. The care team anticipated my emotional needs as a parent and provided resources to help me cope. When we looked at which parental populations were more strongly represented in this disagreement side of the scale, we noticed that percentage of respondents who disagreed or strongly disagreed increased as we moved along that surgical timeline. And this was a significant difference across those stage surgeries, where those parents of Fontan children had stronger disagreement with this statement. The other interesting finding I'll point out is, again, on the positive side, we had strong agreement. We still had upwards of 100 parents disagree with the statement, the care team modeled open communication and welcome feedback on my experience. And when we looked at those subpopulations of parents, the only significant increase in that dissatisfaction was for those parents whose children were diagnosed postnatally. And so they did not perceive as much open communication or the ability to provide feedback on their experience. So in conclusion, the three main themes that came out of this work were unclear interprofessional team roles, unrealistic parental expectations, and lack of open communication. And when we looked at those subpopulations, we found that parents whose children were diagnosed with HLHS after birth were most significantly dissatisfied with the care team's open communication and welcoming of feedback. And it appears that as parents progress through the stages of surgical intervention, they indicate more significant dissatisfaction with that anticipatory provision of resources. So it seems like there's a need for more proactive resources to be provided for these parents, which is one of the recommendations that comes out of this work, along with modeling of open communication and really sincere welcoming of feedback on the parental experience. From this, we recommend targeting interventions around parents whose children are post-Fontan or whose children were diagnosed with HLHS after birth. With that, thank you for the invitation to share this work with this esteemed audience. I'm really honored to be here, and a special shout out to the undergraduate students who led this work. And if she's still on the call, thank you to Katie Dodds for really taking the students under your wing at their first national conference. I know they really appreciated getting to meet you and learn from you.
Katie, that was terrific. Also very sobering. I hope we have it. We're gonna have a chance to talk at the end of this whole session. Here's a question completely off the rails. Have the nursing students decided to go into pediatric cardiac nursing?
I know they're going toward pediatric. I don't know about cardiac yet.
All right, it's a start. It's a start. We'll bring them back from the dark side. That work was terrific. And as Jill and Melissa were talking about before, the whole notion of integration of all of our practices is just terrific. I'm sure you'll be asked at a few more locations to be speaking, Katie, and maybe have your student colleagues do that as well. The last part before I start to turn the world upside down is, which is part of the series. Grace, do you have that video that you can show of our last speaker in that session, Dr. Glenn?
Yeah, I have. I just have some trouble because I connected on Zoom on the other laptop and doesn't have the proper program. So I'm logged in, but I can share my screen. Let me try to promote. Give me just 1 second. I know how to do it.
Okay, that's fine.
Sorry, guys.
In the interim, I would like to encourage people. We had about 2,500 people register for the series, and I suspect that Saturday may not be the best opportunity for people to log in. So Grace has put the link in our chat, and you can just search YouTube for Congenital Heart Academy. But I think the speakers up until now have just been so fantastic, and I hope that you can share this with your team where you work. What I will do later on today probably is in the YouTube link, the description at the bottom, I will break down the times of the talk. So we don't anticipate people are going to speak for all, are going to be able to watch for all 3 hours. And I really do appreciate the nearly 200 of you who are still here, which is fantastic. We have a short video from Dr. Glenn because he's on his way to vacation, but he was kind enough to make a video for us. And if we don't have it now, Grace, we can add it to the YouTube at the end, okay?
Okay, sorry for that, Gil.
No, it's no worries. If you're not having any luck, he's the guy that's on the plane. I think he's out to Hawaii or something. So good for him. For people who, so yeah, that's okay, Grace. We can do it at another time. There's just been problems with that video. For people who don't know Tom, Dr. Glenn is a pediatric cardiology fellow at Rady Children's Hospital in San Diego. He also has hypoplastic left heart syndrome and has a very unique viewpoint, obviously, as being someone who is now learning about and then going to be taking care of children with HLHS. When and Frank, I'm sure it was the same for when you started, the notion that we'd have somebody, that we would have somebody having a Norwood operation, then being on our panel as a pediatric cardiology fellow would have been science fiction.
Yeah, absolutely. I mean, it's incredible, and I guess that crystallizes the journey better than anything else.
Yeah, here's Tom over here on the right. This is Redmond Burke, who's a surgeon at Nicholas Children's Hospital, and Tom rotated down with us for a month in the ICU. He was a medical student at the time. This is the first time that there's a patient with hypoplastic left heart syndrome with a Norwood scrubbing in on a Norwood. And the fact that I can even show that picture now is just truly remarkable. Grace, I'm going to go to my closing words.
I think I can now. Do you want me to try?
Oh, you got it. Oh, great. Let's see. I know it's just a few minutes. Let's take a look at what he has to say.
Let me see. Sorry. Passei a mesma fila. No, I can't. Sorry. There's a lot of things to. No, it worked. It worked. Yes.
All right, you just need to share then. Good.
The Congenital Heart Academy.
You have to mute, Grace.
I'm extremely grateful. I'm 31 years old.
I guess he's going into echo. Sorry, my team's used to the dad jokes.
My parents were
That usually happens when either one of the panelists or someone who's watching is not muted, and probably in your place, Grace.
No, I think it's because Grace is logged in from 2 laptops. It's echoing within.
He's so worth listening to. I hope we can get it to work. Grace, is there a way to turn off the mute?
I locked off.
I think we'll have to stop, Grace.
Now it's fine. Now it's going to work. Sorry. I was really logged in twice, but it was not on the other computer. It was on the same computer. Let's see if it works. Let's try.
Hello, everybody. I'm thankful to the Congenital Heart Academy for this wonderful opportunity. I'm extremely disappointed that I cannot be here with you all live, but I'm extremely grateful that I was able to send a video in lieu of my presence. I am a 31-year-old living a pretty normal life with a Fontan circulation. Back when I was born in 1990, the outcomes for even just the first surgical repair were extremely poor. It was almost unheard of to even discuss long-term outcomes at this time because nobody was surviving. My parents were told not to even proceed because the outcomes were so meager. It's amazing though, now 3 decades later, that the script has completely flipped. Instead of talking about surviving, we're talking about thriving. For many cardiologists listening now, this is probably something they never could have imagined, that people would be living into their 30s and doing the things that they always wanted to. In response to the topic of the session, how are patients doing in their lives? I must say I'm doing quite well. I can confidently say that I live nearly a completely normal life. I've been able to hike the Grand Canyon, earn my Eagle Scout Award, graduate from high school, college, and medical school, and I'm now a year away from completing my pediatric cardiology fellowship and being able to take care of children with the same diagnosis as myself. Yes, I have to take medications every day. Yes, I have to follow up with a cardiologist on a yearly basis. And yes, there's a scar that runs down my chest. But at the end of the day, I and so many patients get to do the things that we love with the people that we care about. And honestly, what more can we ask for? I cannot stress the importance that building resiliency had as a factor that allowed me to live a normal life. The mental health aspect of complex congenital heart disease is one that's often overlooked and perhaps the most important factor, more than anything that EKG or echocardiogram could tell you about a patient. My cardiologists were extremely influential in encouraging me to chase my dreams and not allow my cardiac diagnosis to limit me from anything I wanted to accomplish. Despite this, you can't eliminate the fact that patients are going to feel like there's a lot of uncertainty in their life. Uncertainty about how long it'll be before their liver becomes cirrhotic, uncertainty about how long it'll take until their right ventricle starts to fail, or even uncertainty about whether they could have a stroke at any moment. These are the thoughts that unfortunately go through the minds of a patient with a Fontan circulation, and it often affects the mental health of these individuals. I can speak from personal experience. I went over 26 years between my Fontan and my first hospital admission for a cardiac reason, which was just 2 months ago. I had a TIA following on the contrast ultrasound, and it was one of the scariest moments of my life. And it brought back a lot of old feelings that I thought were suppressed. These are the types of mental health things that patients have to deal with, and in my opinion, are probably the biggest morbidity for adult patients like myself. Overall, though, I think patients are able to thrive and do the things they love. But at the end of the day, the mental health aspect remains the biggest elephant in the room and likely the biggest limiting factor for patients. As we continue to move this field forward, we need to continue to emphasize this and incorporate it into our care, both on the inpatient and outpatient setting. Thank you so much for your time, and I wish I could be there for the panel discussion, but please feel free to reach out to me at glenntm3@gmail.com or find me on Twitter or LinkedIn. Thank you so much.
It's kind of hard to follow that, isn't it? It's just remarkable to hear that story. And again, I think those of us that are senior in this whole process will. I'm sort of all verklempt at this point to hear how he's doing. I didn't know that he had a TIA, but I took care of Tom as a 4-year-old when he had his Fontan, and have stayed in touch with him and his family since that time. I was reminded, and this is Katie still on? Good. I was reminded early time when I first met Bill Norwood, and he would talk about if we can do this operation this way and get a good result, we should be able to get it every time. And it was interesting to hear, what Katie Campbell had to talk about. And I think what's happening now with the Fontan Forward program that you're doing and putting the things that Tom has talked about into motion, so that this is part of our care is truly remarkable. Because as Frank said, and as Katie Campbell said, and as you've said, Katie Dodds, all the second half of this session is we've made great progress with deciding if we like milrinone or not, but we haven't made nearly as great progress in everybody should have therapy and counseling and peer groups and all that sort of stuff. So thank you both for all of you for pointing that out and doing that. And in 10 years, when I'm retired, you're going to run this one, Katie, and we'll see where we've gotten to. All right, I'm going to we're running really low on time, and I apologize for that. I want to, let me see, where is my PowerPoint? There it is. I'm going to do a few things that I'm sure will be controversial, and I will do these somewhat rapidly, and people can watch this on the YouTube. As people I've worked with on this call know that I like on rounds, if somebody says black, that I'll say white, just to see if we can have a discussion about, do we really know what we think we know? And I'm going to very briefly talk about a bit of history, really briefly about the physiology, what we're doing as providers. I can't add anything to what Mark Gavellig and others have talked about. Summarize what was talked about in the last session, and then blow up this entire notion that we should have a Fontan pathway, which I think is so 90s. And it's about time that we stopped doing that. We did Tom. So, the other part I'm going to do at the end is if I were king. which I get to do because this is my series, and want to think about and get feedback from changing the entire surgical paradigm. And so when we think about how we needed to build on incremental steps from the shunt by Blaylock and Thomas and Taussig to Lilly-High's bypass, we saw all of this at the beginning in the video, to the notion that we could do a Fontan operation. Billy Kreutzer and Francois Fontan started the concept around the same time, 1970. Interestingly, and there's been multiple surgical modifications, but interestingly, that operation preceded the approval of prostaglandin. So even though there was an endpoint, potential endpoint for patients with a univentricular heart, we needed prostaglandin to come on board to get these babies with hypoplastic left heart syndrome to first meet surgical options of a Norwood and also transplantation, as you've heard. We moved into the 90s, where nearly simultaneously was the introduction of intermediate staging of superior cavo-pulmonary connections, as well as a fenestration. And we never really had an opportunity to go from Norwood directly to a fenestrated Fontan. Think about that for a second, and we'll get back to that in a little bit. And this sort of 3 planned operations was the standard of care, and is the standard of care in most places. But again, forward-thinking people in Columbus and in Gießen, and my colleague, John Urebicon, who you're going to hear from in a little bit, started to question that approach. So I'm going to start with physiology. There's 5 things I want to talk about: stop doing, saying, and teaching. Balancing the circulation needs to go. Overcirculation needs to go. A target saturation that you get asked about on rounds needs to go. There is no single ventricle physiology, as I will hopefully share with you, and then I'll spend most of my time blowing up this whole notion of a Fontan pathway. A professor once told me, I quote this all the time, is half of what I'm teaching you is wrong. And the problem is I don't know what half it is. And I was taught and then continued to teach in book chapters and on lectures and all that sort of stuff, that the goal of postoperative care is balancing the circulation. And in particular, to have a target oxygen saturation of about 75 to 80 represents a QP to QS ratio of approximately 1. The trouble with these terms, and words are important, is that this is a patient with a quote balanced circulation. If you take a view as an oxygen saturation and a pulse ox of 60% and in their superior caval vein of 25% with an arteriovenous difference of 35, this baby has a QP to QS ratio of 1 and is balanced. Unfortunately, he's about to have a cardiac arrest. He's very, very sick. So the term of trying to balance the circulation is not specific. It doesn't really tell you anything about adequate oxygen delivery. And similarly, having a goal oxygen saturation, say of 80%, is meaningless if you don't know the mixed venous saturation, and is meaningless if you don't know the pulmonary venous saturation. So here's a baby with our goal saturation of 80%, who's in profound low cardiac output. So using those as goals of therapy are inexact. It's not sensitive, balanced is not specific, and it's really just time to stop saying those words. We're not teaching a very complicated physiology. That's from The Princess Bride, by the way. We're not teaching this the right way to our students and to our nurses. And we have to stop. We have to use correct terms, and I have some preferred terms. And that is, and pulmonary overcirculation is another one of those bugaboos that really bothers me, because in every other lesion, our goal is to maximize oxygen delivery and to maintain the combination of cardiac output and hemoglobin, et cetera. Pulmonary overcirculation may be important, I guess, if you've got lung disease and now you've got lung water in there, but low systemic blood flow due to high pulmonary blood flow in isolation happens, but in my experience has been a pretty rare event. Pulmonary undercirculation matters if a shunt is a problem, but most importantly, systemic undercirculation, not pulmonary overcirculation. Systemic undercirculation does matter. So don't say overcirculation if what you mean is systemic undercirculation, because this is complex. Mark went into some of this early on. We've got our O2 delivery determined by systemic blood flow and oxygen content, which is determined by how well the lungs are and what your hemoglobin is. And now your single right ventricle has to provide the QS. The single right ventricular output is based on a number of factors such as afterload, preload, myocardial function, and heart rate. And then that ventricle also provides pulmonary blood flow. So to have a patient with low oxygen delivery and talk about it being the ratio of these two numbers or having a target oxygen saturation is highly simplistic. It's also important to remember that there's a regurgitant fraction that goes along with this, mostly tricuspid regurgitation. So if a patient has low systemic oxygen delivery, it's not over circulation. It's something in this pathway. This is what I would call a multi-distribution circulation. And it's possible that it's maldistributed with more pulmonary than systemic blood flow, but that's not the whole picture. So we need to get rid of these simplistic and outdated concepts. I talked about this in more detail in one of the earlier series, which you can find on YouTube if you do want to look at it. Okay, so I've seen a whole bunch of papers that talk about single ventricle physiology. I just want to share with you a few of them. Here's a Fontan paper in single ventricle physiology. Here's growth with, quote, single ventricle physiology. Here's neurodevelopment with single ventricle physiology. And here's an interactive tool. And then here's just a few more in the Pediatric Heart Network. And all of these manuscripts talk about single ventricle physiology like it's a thing and a universal thing. There, in fact, are 765 papers that use those terms on a PubMed search I did earlier this week. But you can't really think that on the left here, a baby with newborn with an open duct and HLHS has the same circulation, how the blood goes around, than the top one here in the middle, which is after a Norwood with a Blalock-Taussig Thomas shunt or an RV to PA conduit. I want to thank Dr. Richie, I hope I say this right, Richie Ardi from France, who's just been drawing wonderful things that she shares on social media. And this circulation, this physiology is different than all of those. So what is single ventricle physiology? Well, some of those papers talk about a bidirectional Glenn or a hemi-Fontan or a classic Glenn or a bidirectional Glenn with accessory pulmonary blood flow. And then there's the Fontan and all these modifications of the Fontan. So if you're writing papers, please don't write papers that we did something for single ventricle physiology. It's a patient that has a functionally univentricular heart, and wherever they are in their circulatory management and their reconstruction should be described. But we have to take that one out of the papers. But I want to spend most of my time oh yeah, so we talked about that before with the pictures. So there's a bunch of different ways the blood can go around in these kids. So again, we have these non-specific, non-sensitive terms that are too simple and we've used for too long, and it's time to change them. But now I want to blow up this notion of a Fontan pathway. And I can see the reactions, even though I'm on Zoom, from many of you. We all learned that this is the way to go. We've seen a whole bunch of papers. Katie Campbell's paper talked about all through the stages as though this is the way that things need to be. And then more recently, in our book, in Anderson's Pediatric Cardiology, yet again, I started using non-specific terms and looking at a pathway that is so 90s that I think it's time to change. So what is a good result? Mark really set this up. Survival is necessary, but insufficient. Physiologically, we need a patient that's got a Fontan circulation that can have the highest possible cardiac output at the lowest possible central venous pressure, both at rest and with activity. And I believe that that would then lead to taking this lethal condition and obtaining a circulation with the highest possible quality of life for the longest period of time. And as the second half of this webinar showed, it's not just about the heart. So how are we doing with all of that? This paper was published I didn't beat you, Katie Dodds, with an announcement from 2 days ago, but this was from 2 weeks ago out of Germany. And again, shows this no difference between the total cable pulmonary, no difference between the shunts and BT shunt and Sano shunt. That's out to about 15 years. So let's talk about this so-called pathway that we preach as gospel. How are we doing? Well, by elementary school, A whole bunch of kids had not survived. Of those that were alive, many of them have some sort of neurodevelopmental challenge. And in addition, a small number are being transplanted. So if we then talk about this Fontan strategy that we took, the patients are now adults, so that means they were operated on in the 90s, right? Early 2000s. We've only achieved that rock star outcome in about 10 or 15%. We've achieved a pretty good outcome in another 25 to 30%, so somewhere in the 40 to 50% range. Those good outcomes are minor things that they've had to deal with in school, whatnot, but functioning and doing very well. Another 10% with more significant neurodevelopmental challenges. That's me in the upper left, looking after this little baby with hypoplastic left heart syndrome who turned into this young man. You can't necessarily know what went on in those stages, except he wore glasses and he became a chef. And he unfortunately passed away in 2014. But this was sort of, again, the best outcome we could have hoped for 35 years ago. You've just heard from Tom Glenn. This is another one of my patients who's now, he's the 26th, I think, patient who had a Fontan after a Norwood. He wears the number 26 a lot. Same kid, same young man. He certainly has been through his procedures. There's another pacemaker change. And if we look at that group that Tom was part of, those numbers of rock stars is even less. So we're making good progress. But where do we go from here? If we're back to this group of patients now where only about half, I would say, are having a good outcome, we have to do better than this. We can't be satisfied with this particular outcome. There's a lot of things, as Katie mentioned, that have to be monitored for. I like the idea that you talked about, Katie, of going from a sickness model, which is all this stuff in here, to a wellness model. How can we do better over time with this group? And if nothing changes, nothing's going to change. If we keep doing Norwood, Glen, Fontan, Norwood, Glen, Fontan, let's see how you're doing. As Sheree said, normalizing the Fontan circulation. We're not going to make any progress. Dave Brown talked a lot about the NPC QIC and how we've been doing incremental improvements. The Fontan network and other things are really improving proactively how children who've been through this pathway are doing. But I think we really need to rethink this entire process. As Einstein said, we can't solve our problems with the same thinking we used those problems. And I'll give you a couple of reasons why I think that the pathway, as Tom Glenn said, is dark and unknown and probably needs to be rethought up. So I strongly believe we have to rethink this, and that the choice of procedure we do is based upon the baby's individual physiology and their individual responses to preserve their myocytes, their pulmonary arteries, arterioles, and capillaries, their neurons, their nephrons, their patients, and minimize central venous hypertension. That should be our goal. And if we rethink how can we do that, not based on what operation is better than the other, but what should we be doing in a particular patient, I think that we'll start to make some progress. And I think we need to, from a surgical perspective, rethink two fundamental truths. And that is that a newborn operation and procedure is necessary on bypass for many kids, and that a Glen is necessary in all patients. As you're hearing, in addition to interstage monitoring, we need plans for all other aspects of those patients' life, developing a healthy lifestyle plan, and developing a roadmap of neurodevelopmental care for both the patient and the family. So let's talk a little bit about the surgical thing. And so you have to be ready to abandon your ideas and think about, are we doing the best that we possibly can? So Harvey Karp is a developmental pediatrician who publishes about the 4th trimester that babies are born early because their head is disproportionately large. And it takes about 9 months for full organ maturity. A normal baby's head circumference is 11. So in fact, many things that babies go through may be due to their immaturity and premature birth. And he talks about a 4th trimester. 1/3 of moms experience postpartum depression, as you've heard earlier from Frank Casey. Now add complex congenital heart disease on top of all of that. So I want to talk about these 4 organs. During the transitional circulation, there is a acute increase in pulmonary blood flow in the structurally normal heart, as well as in a patient with by 200 mLs per kilo, as well as in patients with hypoplastic left heart syndrome. This is data courtesy of Mike Seed up at Sick Kids in Toronto. Is the transition any different? Well, it turns out that the single V as a fetus has slightly lower combined cardiac output of 375, which nearly doubles, has to double within the transitional circulation in the first few days of life. This is work done by Luke Eckersley and Lisa Hornberger up in Stollery, Edmonton. It's in press right now, and I just want to show you some data that will be published pretty soon. So on the left axis, there is the combined cardiac output of the right ventricle and the left ventricle in the dark line of patients with 2 ventricles, and in the top line with hypoplastic left heart syndrome. And as you can see, by 48 hours and then on to 96 hours, the single right ventricle must basically double its workload rather acutely. And that results in a couple of things. It results in decreased systemic blood flow, decreased cerebral blood flow, and decreased gut flow. And when we start thinking about what do we see in these babies, neurodevelopmental impairment, necrotizing enterocolitis. And much of this may be set up may be set up prior to surgery because of the stress of the transitional circulation. In addition to the volume going up, the mass does not increase. In mice, the ability to go from myocardial hyperplasia to pathologic hypertrophy takes a while. And I believe in humans, I think I have that data on here next. Yeah, in humans, it takes a doubling of the body surface area to start to have a left ventricular end diastolic volume that's matched to the left ventricular mass. So now we have a baby with HLHS who's had abnormal circulation as a fetus, is born, the lungs expand. We ask the right ventricle to then double its workload without any consequent hypertrophy and no increase in mass. So blood flow goes down. Heart rate can only tackle so much of that in terms of a limited stroke volume. I think what happens in many of our kids that have basically no tricuspid regurgitation, that acute load will result in worsening tricuspid regurgitation. We see that frequently in babies in the intensive care unit. And I'll go back to this. And the surgeons know that acute stretching of the heart when they see that in the operating room is very poor for the myocardium. And so take this baby now that's had this acute volume load, not time for hypertrophy, and you do a Norwood operation and you deal with low cardiac output and lactate goes up. And it's not surprising that we see the data that Wes showed us earlier, that there's 10% seizures, 15% cardiac arrest, 18% ECMO. And it's not that it's not a technically good operation, it's a technically good operation in a very sick, immature host. Now let's talk about the kidney for a second. If we have normal kidney data, this is from dogs where the GFR, the glomerular filtration rate, increases linearly in 80 days. And in children, that's more of an exponential model where the glomerular filtration rate really becomes normal at about 2 months of age. And this is work we did in the Primacorp study where that exponential rise is delayed in the first 36 hours after bypass, where the GFR is only about 1/2 to 2/3 normal. So now here we have a patient that gets a Norwood, irrespective of the shunt, that has poor ventricular compliance, mass volume mismatch, a limited ability to increase cardiac output, cardiac arrest, low renal perfusion. They can't clear fluid. They have anasarca. We've all seen these patients. So should we still be doing this operation? I think we have to ask ourselves now, should we still be doing this operation in the neonate? Because after the neonatal period, we get ventricular mass. We've all seen that 3-month-old babies that get surgery are very, very different than those that are newborns. The GFR goes up, they're better nourished. And importantly, the family has gotten through that immediate stressor of childbirth. What are they doing with the siblings, financial issues, etc. And then the brain, I'm not going to go into all this because we're short on time. Probably the simplest way, you can look at these references on the YouTube channel, but the simplest way is to use head circumference as a surrogate for brain growth. And this is what happens in the first 3 months of brain growth in children that don't have congenital heart disease. Cerebral oxygen delivery falls every single day prior to surgery. I can't emphasize this enough in terms of timing of surgery in non-HLHS. Great work by Jennifer Lynch and Dan Licht. I think Dan may be on this call, that shows that the oxygen ejection fraction on the bottom increases and cerebral blood flow decreases. This has been confirmed with the work that I just showed you before from Edmonton, that as pulmonary blood flow goes up, cerebral blood flow goes down. I borrowed the slide from Melissa Jones. That's the developing brain at home, and that's the developing brain in the cardiac ICU. And I put all of this data here up front to set up the notion of what I want to recommend, is that this is where we should be with the developing brain in the CICU, not fluid overloaded on a lot of drips with sedation medications, EEG leads, etc. And I'll show you that in just a second. The other thing I want to point out developmentally is about the lungs. And that if we look at alveolar and capillary growth, long before they're at their peak, we cut down pulmonary blood flow with a bidirectional Glenn. If we look at the alveolar number, again, when we superimpose a Glenn, there's still a lot of alveolar and capillary growth to happen, but we've cut the antegrade pulmonary blood flow down. And this, in fact, may be one of the reasons we see so many aortopulmonary collaterals in kids with a Glenn. Again, I don't want to go through all these references, but look at when we intentionally cut pulmonary blood flow down in patients that are going to undergo a Fontan. Okay, so we do know that the reason we did this, right, is we were having kids, and somebody, I think Mark said this earlier, that we went from a Fontan, from a Norwood directly to a Fontan, and there was a lot of problems with supporting that patient. That happened in the days before fenestration, which, as he showed, bypasses the bottleneck. And although this does reduce the ventricular volume work, the Glenn also significantly reduces flow to the pulmonary arteries, capillaries, and alveoli, with significant implications for what I would consider a good Fontan over the long run. Are these pulmonary arteries going to be a good solution for a Fontan operation? They don't grow after we do that operation, so we're stuck with what we have. So our standard Fontan pathway right now, we start by doing an operation when the renal function is marginal, the myocardium is adapting to a volume load, the brain is immature, and we see all of these problems, not too surprisingly. The longer term issues, of course, we've heard about in the second half of this webinar. Chronic kidney disease does occur, developmental disabilities. So to skip on to what I think is the most controversial thing that I want to talk about, I think we have to rethink this pathway. And this is what we need to do. And much of this has been really, in the last 3 years, I've been thinking a lot about this since I started to work with John and looking at the hybrid approach to this disease. We've heard about the Fontan Dam. When you think about it, it's a series of locks. It's a series of potential obstructions. And as Mark so elegantly put it, it's the one single worst one of these. That's the area that we can work on. And although we tend to draw the Fontan circulation this way, I think of it more as this series of steps where we have problems if we don't have these three areas optimally managed from the time the baby is born. The central pulmonary arteries and their branching, the pulmonary vasculature, and the myocardium. and the AV valve for that matter. So if we have all of these working well, on your left, you see the CVP. If we start to lose lobes of, that's our nice Fontan physiology. If we start to lose lobes from bad pulmonary artery architecture, it's suboptimal, but it's pretty good. The CVP may not be too high. If we have that as well as some vascular disease, now we're starting to have fair Fontan physiology with elevated resistance. And you can see that big resistor up at the top. And then finally, if the ventricle is also dysfunctional, now we have poor Fontan physiology. And the CVP just starts to go up and up and up. And this is, as I want to emphasize what Cherie said, this is not the time to refer for transplant. It's before this time. I had to put this up. If you think of the Fontan circulation as a series of locks or a canal, you don't want to refer for a Fontan when the major blockage is basically now at its worst possible scenario. So physiologic principles, we all know these: unobstructed systemic blood flow and pulmonary venous return. Limit the pulmonary blood flow without distorting it. Unobstructed systemic venous return, sinus rhythm, and AV valve regurgitation. So here's my, if nothing changes, nothing changes. Rather than saying I have to do arch reconstruction with a septectomy and a BT shunt, that's called a Norwood, or I have to do arch reconstruction and a septectomy and a BT shunt, excuse me, and an RV to PA conduit, that's a Sano, or I have to do arch reconstruction and a septectomy and a cavopulmonary connection, that's a comprehensive stage 2. We have all of these tools. How do we best approach that physiology? And why is freedom from death or transplant a thing? If I have a choice between those two things, I will take transplant. Okay, we talked about those before, so I am going to talk about the first thing. The first evaluation baby with HLHS is their atrial septum restrictive? And now we have 3 options to deal with that. But if they don't have a restrictive atrial septum, now we want to be sure we have unobstructed systemic blood flow. We start with prostaglandin. We could use a ductal stent, or we could do what Norwood described, which is a surgical arch reconstruction. And I remember hearing him say that all we're doing with the surgical arch reconstruction is converting aortic atresia to pulmonary atresia. Now we know what to do for pulmonary atresia. That's a shunt. And of course, the choice of shunt is dependent upon age, the PA size, and the PVR. And remember that a comprehensive stage 2 as part of the hybrid strategy is just the arch reconstruction with a cavopulmonary shunt instead of a systemic shunt. Limiting pulmonary blood flow, as I talked about, I think has to happen very early because of what I talked about before with the myocardial dysfunction as well as cerebral and gut dysfunction. So we can do that with a shunt, a Sano. We talked about those before. That's how we get pulmonary blood flow. But how do we achieve these lifelong principles to get to a Fontan? So this is what I think some parents think the Fontan pathway might be, or some of us might think the Fontan pathway might be. And as we've heard over the course of today, it's more likely to be something along these lines. How do we minimize and attenuate these necessary downtimes for these patients? So this is the if I were king part. That's from A.A. Milne. So as soon as possible, check the atrial septum, start prostaglandin, and then I strongly, strongly believe that within 24, maybe at the latest 48 hours, and again, Gabriella, thanks for this drawing, the pulmonary artery should be banded rapidly to prevent all of those low flow states, protect the brain, protect the gut, protect the myocardium, protect the tricuspid valve. That does not necessarily mean that you need to also add a stent. That just means the physiology is too much pulmonary blood flow that's affecting a limited ventricular reserve in a multi-distribution circulation. And John, I want to thank you for these ideas. It's been, John's on here and hopefully we'll answer some questions in the panel, but I never would have changed my thinking as radically as I have had I not had a chance to work with you. So thank you very much. This should not be what newborn HLHS care looks like. I strongly believe it should look like this. The bands get put on, prostaglandin gets started, and we see how the baby thrives. Let mom recover from her birth. Let the sibs come in and see the baby. Start feeding, start breastfeeding, start skin-to-skin care, all the things we've learned from neonatologists to maximize neurodevelopment. Wait for the kidneys to mature. So if your baby is doing well with prostaglandin and the kidneys are maturing, you can then make a decision, do I want to put a stent in or do I want to do the arch reconstruction? There's no definite pathway that one needs to take. You see how the baby does, and if they're thriving with an open duct, go ahead and change the prostaglandin for a stent. If that physiology is not working, figure out why and fix that. Look at the pulmonary arteries, measure the physiology, measure the creatinine clearance, be sure the baby's feeding well. And then once the baby's through the neonatal period, then it's going to be the time to expose them to the bigger stressors. And every baby's going to be different in this approach. The next thing that I really think we have to start to reconsider is, do we always put in a superior cavo-pulmonary connection? Because that's a balance between what's good for the heart that's not good for the lungs. So we've never had the opportunity to go from a systemic to pulmonary artery shunt after a Norwood or during a Norwood directly to a fenestrated Fontan, which I think might be a good approach for many patients whose heart is okay. That's the approach that these guys had. And that because that's all we had. We have a much better ICU approach. We have better anesthetics, better surgery. Everything else is better. We should not abandon that as always doing a bidirectional Glenn. We've heard that from Tom as well. If the heart's not great and the valve's not great, then I think we should probably go and volume unload that ventricle and keep a very good eye on the pulmonary arteries for growth. Remember, transplant is a therapeutic option at every single state. It's a great treatment for failing physiology. Don't wait too long, as Sheree said. And this was one of the clinics from one of the papers from, I think it was Ben Idem, and it was an editorial from him and Frank Setta, who were talking about responding to a paper, and they said, stop creating bad Fontans. And I think by holding the notion that we have to go hybrid, comprehensive stage 2 Fontan, or Norwood bidirectional Glenn Fontan, fenestrate or not, we have to stop forcing these kids into that pathway if it looks like they're not going to do well, and speak with our transplant folks earlier. So a perfect Fontan, as we've heard through this, and I'll close with this, will provide the longest duration and best quality of life. That's the highest possible cardiac output at the lowest possible central venous pressure at rest and with exertion. So these types of surgical changes are hopefully going to change the notion that we have patients with high central venous pressures, cirrhosis, plastic bronchitis, etc. It will minimize the early consequences to the liver, gut, lungs, kidneys, and brain, but also the later complications of chronic central venous hypertension. So here's what I would recommend. Change the neonatal and surgical management at this point to an individualized approach based on that individual patient, but it always starts out with atrial septal evaluation and pulmonary artery banding bilaterally, banding to decision. An active program, as you've heard, to support neurodevelopment and support the family, active surveillance and treatment of residual lesions, and proactive exercise, diet, and psychological support for our patients. If I was live, I'd imagine that I would have a target on my chest, because I know we have some surgeons and other things that are coming up. But I'm happy to discuss these principles, and thanks very much for letting me finish the GW series at this point.
Hey, Gil, this is Jeff. That was a fantastic talk, and this whole session has been really great. So congratulations for putting it all together. You talked a lot in your presentation about modifying the pathways towards getting a Fontan and how to get there the safest way with minimizing all the associated comorbidity. I wanted to bring up an issue after that, which is, at the point a Fontan fails, what's the best pathway forward, and something we've been seeing a lot more is when these patients fail and they need a heart transplantation, quite often their liver is really in bad condition, and trying to do a heart transplant with a failing liver doesn't go so well. So then it's a combined heart liver transplant, which may be better. And just like that's a little bit of a paradigm shift. How do you get to the Fontan? Another one is, what do you do when the Fontan fails? And I was interested in your thoughts, or anybody's thoughts, about the role of heart liver transplantation in a failing Fontan rather than just heart transplantation. Mute.
I hope we don't get to that. I'm going to ask Shri and Katie, if they're still on, to put their slides on, to put their cameras on, to sort of get at this. I hope I remember in Toronto about 10 or 15 years ago, Andrew Reddington posed the question that all children with HLHS should get a heart transplant before their 18th birthday. Talk about controversy, right? You take a well person and put them in that area. So I think the best ways are to not get to the point you described. And let me ask Katie first what your thoughts are on that, and then Shri, and then John.
I agree with you, Gil. I think the goal is to much better fine-tune being able to decide when they're about to fall off the cliff, and not list them for transplant once they've already fallen off of it. And I think that there are clues, and I think that you know who those patients are, but transplant has been associated as, that's somehow looked at the idea that our approach has failed. And I agree, we should get rid of the idea that we should change the language about transplant, and it should be in the constellation of options at all times.
I think you're absolutely right. The math shows there's not enough hearts available to transplant all of these patients, for sure. Right. But there's a subset that's their best pathway forward. I wouldn't view that as a failure. I view that as we're finding an alternative strategy to let a patient live a meaningful life.
It isn't always easy, because I think I have a lot of patients that walk on the cliff and are doing fine, and trying to look at your crystal ball and decide what's that moment when they are, getting close to falling over the edge. I wish we were better at that, because I think sometimes we do wait too long.
Shri, you want to comment on the normalization of the physiology? And
yeah,
I just want to say one last thing, because Katie taught me this as well. It's better to have one hepatologist look after 30 patients' livers than 15 hepatologists know about 2. And I think it's the same thing for the primary cardiologist of Fontan patients. I think they should not lose a patient they've cared for in a family, but they should partner with a place like CHOP and other places, so that there are people who are looking at the Fontan through the lens of a wellness program and a sickness program. Shri, I'm sorry I stepped on your answer there, but.
No. 3 quick things before I forget. I think the responsibility that we think is ours is to look into that crystal ball and give advice to the family when is the right time. As cardiologists or people taking care of anybody in the Fontan, not just cardiologists, all the team members, I think we take it upon ourselves to be that person who says, now is the time to go in and get that transplant evaluation. And in doing so, we end up being extremely cautious, and in fact, are not realizing how badly we are hurting those patients and those families. Primarily because I think, and then hopefully it's a generational thing, wherein cardiologists will accept that suboptimal outcomes are suboptimal, that just being alive is inadequate, and we cannot accept that. And until we have that frame shift, making that their responsibility to hold them off, to save them from a transplant team, cannot be changed. And that is on us. That is completely honest. So it's part of our education. And then to Dr. Jacobs' point about the liver issue, again, ideally you want to go in before that is due, However, I think the liver may actually be less of an issue than the kidneys are, in my opinion. And we haven't looked at the Fontan. There isn't a Fontan alive and is 10 years out, I bet, who has a GFR of 90 or greater, a completely normal GFR. Those Fontans are going to be extremely rare, again, specifically hypoplastic left heart Fontans. So the kidneys are taking a hit, and what we're recognizing is that the liver may have much better regeneration, which we know about, compared to kidneys. And patients who have Fontans who have a CKD grade 2 or higher, so EGFR is anything less than 60, will have very high post-transplant mortality. And those patients actually do significantly better with the heart kidney combined than heart alone. However, when it comes to the liver, that data may not be as clear-cut. I just reviewed the last 50 Fontan transplants from Emory, and they've had only one death in that cohort, and no heart liver, even though all of their livers are very systematically evaluated, and no transplant, no heart liver done at all. So all these are, again, just failing Fontans requiring heart transplantation. And here at Children's too, we have done 3 failing Fontans recently, 2 of which were advised heart liver transplantations at other centers. And both their livers are recovering already within 6 months. So I think that the liver does have some hope in terms of regeneration, but there obviously may be a point of no return. We have to be careful about that. Again, it does take a lot of frame shift in terms of the thinking, I think.
Thanks, Shri. I'm going to ask John to just have a few minutes to make some comments, and I think John's still there. Just don't see his lovely face. Dr. Urebican started the hybrid program at started the hybrid program at Children's National. Just presented the data at the AATS, and we're all looking at this through our different lens. John trained in Gießen with an amazing experience. That we all know the Columbus experience. So when we put together a lot of people in one place, and I'm really fortunate now to be at Children's National with Norwood experience and Sano experience and hybrid experience and neurodevelopmental experience, and Melissa, who had to run, is running I think the first cardiac neurodevelopmental ICU program in the country. And things we've learned from Jackie Sands and from Frank Casey, we have a great opportunity to change the paradigm. And I want to say one last thing, John, before I turn it over to you, is I heard Adrian Kovacs say this recently, and that is consequences of the Fontan should be expected, but not accepted. We know what they're going to be. We shouldn't just accept that, as you said before, that I'm just happy the kid's alive. We have to do better. John, I'll turn it over to you for your thoughts on both Dr. Jacobs' question as well as anything else, because you're going to be doing a lot of banding, I hope, now. So
thank you. Thank you, Gil. I first of all, it's a great pleasure to be in this panel, and I really, from my heart, thank you for your kind words. If I had any minor contribution to some paradigm change, which you are actually promoting and advocating, and I really appreciate that. I think we had a great 4 years, and then I have to say, Gil is always. I don't drink coffee in the morning, and in the morning rounds, Gil is always waking me up with his contrary comments, and I really appreciate that every morning. And that's actually similar in our hybrid program. And new to me was in Washington D.C. also starting the hybrid program, changing from the straightforward thinking of banding to ductal stenting to banding to a delayed Norwood versus other options, or banding to a decision. And I think I really appreciated your support in that matter by thinking forward what we can do with banding more than just bridging the patients to a stenting. Ductal stenting. And I think coming to the question of creating bad Fontans, I agree. And when I look, I had spent about 4 years in Gießen, and I want to give the credit really to my colleagues there who taught me all this hybrid approach, and particularly to Dr. Dietmar Schranz, who had the crazy idea in Gießen, a small town in Germany, started the hybrid program, one of the biggest actually in the world right now, with over 300 patients, I assume, right now. And when I look at their experience creating bed Fontans and what about the transplants, how early, when we and I'm talking maybe too much from the hybrid perspective, but when we propose parents the hybrid approach for the treatment of HLHS and variants, and also HLHC, the hyperplastic left heart complex patients, we propose them three different options. One is the single ventricle palliation as such we can think of. And the second is particularly for HLHC patients going towards the biventricular repair. But particularly we propose them also say hybrid is a bridge to anything, including the transplant. And when we show our pathways for treatment, and I think that's important here, it's important to observe a neonate in the hybrid circulation, either with an open duct with prostaglandin or a stent, how well this physiology is tolerated by the patient. If this physiology is tolerated well and the patient is doing well, you can certainly proceed any way you would like to choose. But if not, the decision as early as before going to stage 2 can be made for a heart transplant. And that, I think, is a great opportunity for some of the patients who would otherwise would go through cardiopulmonary bypass, cardioplegic arrest, and all of the intensive care measures before going to transplant, and have a very bad transplant candidate. And when I look at Gießen approach, there are actually about 7 to 8% of patients from the stage 1 went towards transplant. And at stage 2, the number of these transplants has come down to about 3 to 4%. And after Fontan, from my analysis a few years ago, about 70 patients who completed after the hybrid approach to Fontan, only 2 patients actually who were transplanted and needed the transplant. So I think I agree with what has been said, and the decision for transplant should be as early as possible, and maybe just don't do bed Fontans. We have the courage to say, okay, well, we have done well until the Glen, or even just stage 1, and this patient would deserve another consideration for a more advanced option like heart transplant, and I agree with that. My comments to that are these, and if there are any other questions with regard to hybrid, I would be happy to comment on them too.
Thanks so much, John. I do want to add to some of the data. It's now 20 of the hour, approaching 4 hours. So I'm just going to mention one last thing. Well, 2 things actually. The short one is that the days of Bill Norwood just being the innovator and doing it in one place, or Dr. Castaneda saying, okay, try a fenestration, and learning in one center are gone. So however we decide to move as a community to try to make this better, if I've convinced anyone, including my own institution, that we have to change things, we have to collect the data and share it. That's absolutely one of the most important things. And then the second thing that I want to add is, and Frank and Jackie are still on here, it's very preliminary, but there's preliminary data from Von Rees, John is his name, looking at MRI data at 6 months and comparing kids who have a Norwood versus those that have a Sano, and although it's a Norwood versus a hybrid. And it looks as though the very preliminary data, not long-term data with predictive validity, is that brain growth is different and more positive with a hybrid approach rather than with a Norwood approach. And it behooves all of us to be sure we're collecting data and sharing data in all of these evaluations. Grace was nice enough. Grace was nice enough to put in the chat. Is there any data to support the benefit of PA bands as the first step? No, absolutely not. I think this is pieced together with the developmental biology, my own personal observations, and my new personal observations with how well kids do with a band and then a delayed Norwood, as well as a band and a comprehensive stage 2. So
I think it was Tim. I think it was Tim because he's
oh,
using
Tim.
the link. Yeah.
Oh, he's using your login.
Yes.
Oh, I thought it was you, Tim Nelson from the Mayo Clinic. Thanks for
Yes.
thanks for your question. Are you still on? No. He asked the question.
So, yeah.
He asked the question and ran. Tim's doing great work with Mayo. Katie, I think Chop is in the group now. Oh, there you are. You don't look like Grace Van Leeuwen.
Hey, Gil. Great job.
Good to see you. We'll have you back to talk about this wonderful work you're doing with stem cells. Who are the organizations in your the institutions in the consortium now?
Yeah, we've got 11 institutions in our HLHS consortium that span from CHOP, CHLA, Mayo, Minneapolis Children's, Oklahoma, Alabama, Ochsner, Denver, and Sick Kids.
Well, we've got a lot of international. We've got a lot of international people on the call, so maybe they'll contact you with interest. Describe what you guys are doing with trying to get the heart to look better.
Yeah, our bias is that the heart of the problem is the heart, and all these pathways need more heart muscle. And we believe that regenerative medicine, stem cell biology, is a pathway that needs to be developed more. And we're in phase 2 clinical trials testing autologous cells. More studies to be launched, and we are eager to continue our partnership with the philanthropic community and institutions to drive the paradigm that a bigger heart is a better heart for all of these options. And regenerative medicine and cell biology is coming of age in the congenital heart world. So we'll have plenty other times, Gil, to talk more in detail on this.
Now we're definitely doing a part 2 webinar, Tim. That's great. That's Tim Nelson from Mayo Clinic. By the way, if you do immediate pulmonary artery bands, you still have access to the coronaries to put those cells in. So we can have another arm if you choose.
We've thought about that pathway a lot. That's why I was quite interested. Delaying the Norwood with a pulmonary artery band would allow processing of autologous cord blood to be a more viable option at 1 week versus 1 day. So I'm very interested in that. I think there is much benefit to myocardial preserving the myocytes by using a cell-based therapies. We're not going to necessarily change it into a 100 horsepower engine in 1 day, but we think that there are techniques that can definitely stimulate and preserve the myocytes at these earlier stages. And we think that translates into long-term outcomes. So the data has to prove that, and that's what we're in the process of collecting right now.
That's wonderful.
That's great to hear. Because early in my career, when I was working with one of the pioneers for stem cell therapy in adults, Professor Steinhoff in Germany, I used for the first time actually experimentally autologous cord blood mononuclear cells in a congenital model, and that was a fun experiments, and very in sheep. It was great, and I think that has great potential. Unfortunately, I couldn't pursue that after that. So to the question, there's no head-to-head comparison banding versus the Norwood first stage. We can only look on results from centers which are dedicated either to Norwood primarily or a hybrid. What I can tell is in the last about 10 to 14 years, when I left Gießen, 10 years, Gießen had seen no single mortality after bilateral pulmonary artery banding in all comers. So this is a dedicated center, and they do exclusively hybrid, and they are actually doing this for now over 20 years, and with a cumulative experience of 300 patients. So this is the one thing. The second is in the best centers, I think when we take United States and doing the Norwood approach, I think we can approach survival as high as 85, 88% range. I think survival is the one thing, of course, how patients do afterwards is also important. 10-year results so far is published from median. So follow-up 10-year results from Gießen is that they can achieve in all comers a survival of about 80%. In the hybrid in the HLHS population. So if there is no evidence as such when we talk about evidence and scientific, but I think when we look at the results, there's certainly great potential that we can help the higher risk, not only the highest risk, what we do nowadays, but the higher risk Norwood candidates. HLHS patients with the hybrid approach. And I'm sure either combining these approaches or with Gil's ideas, we can achieve in this patient population, which is the most important thing is to start with, survival about above 95%. And then from there, we heard a lot of nice things about further follow-up and neurodevelopment. I think the future is bright for these patients, and stem cells certainly will have a great role in the future.
All right, I'm gonna wrap things up. I've learned a lot. This has been really a terrific session. Tim, you've bought yourself a webinar, which is terrific. While you're at it, get some fibroblasts and grow a patch you can use as the arch reconstruction. So then we won't have all of this desensitization. Or the sensitization for our transplant colleagues.
We'll talk about that next time as well then.
Perfect. Well, I want to thank again Sasha and Grace and people. We've had like 6, 7, many countries. Boy, we've had, let's see, we've got Ireland and we've got, is Minnesota a separate country yet? No. We've got Belgium. Again, this is, for me, these kind of sessions are the silver lining of the pandemic, that we could all talk about this today. And we look forward to the next series. Thanks very much, everybody. Grace, any closing thoughts? The real Grace? Grace is on vacation. I think she's in Cancun and was kind enough to share with us today. So again, thank you, everybody. Thanks for joining us.
That was great, guys. Thank you very much.
Katie Campbell, thank you. It was great to have you. It really was.
Thank you, Gil.